Ready? Okay. Good afternoon. Today is February 25th. Today is February 25th, 2026, and it is now 4:05 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So now I'd like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee and the Board of Managers meeting at approximately 5:30 p.m. Unless a member of the public wishes to comment on a specific item on this agenda now, we will welcome them to do that. And if not, we will proceed to the committee agenda. Members, the first item is the approval of the minutes of the January 28th, 2026 Budget and Finance Committee meeting. Do I have a motion?
So moved. Second.
So having a motion and a second to approve the meetings, all those in favor, please say aye.
Aye.
Aye. So the motion passes, those opposed, those abstaining, the motion passes unanimously. The second item is to receive a presentation on review and take appropriate action on the Central Health Fiscal Year 2025 financial audit and receive a presentation of the audit results of the Central Health component units. And I think we decided to move that item to March of the next month, Jeff?
Correct. Jeff Knodel,
Yep.
CFO. Yes, we are postponing the item. The presentation that we had is in your packet. We should distribute the financial statements in the next couple of days, and then we'll come back in March with the external auditors for a presentation.
Great, thank you. And members, I just want to point out that this gives us almost about 30 days for us to review, and I would strongly suggest that if you have any questions, to either call or email the administration to get those questions answered around the audit and the presentation itself. And by the way, Jeff, just so that members also know, the deadline for approval of the audit is no later than March 31st, 2026. So we're on
Correct.
track to get that approval in the next month. So
Correct.
yeah, thank you. The next item is to receive the January 2026 financial statements for Central Health, and Nikki Riley will be presenting. Welcome.
Good afternoon, Nikki Riley, Deputy CFO. Presenting January financial statements. I do want to let everybody know that Central Health, they present their monthly financial statements. CUC presents their monthly financial statements after presenting to their board. Sendero does not present monthly financial statements because those are confidential until they report those to the Texas Department of Insurance. So these numbers are just Central Health, just for everybody's awareness. I'm just going to go over the highlight page, and I think you guys have had this since last Wednesday, and so I'll just break after the highlights for questions on anything else. Our tax collections, January 31st was the deadline, so the majority of tax collections came in this month. We are at 85.6% of the adjusted levy versus 90% last year. That is, it's not a problem. There's so many collections coming in at January 31st. A lot of times tax office cannot get all those in. So I looked at the beginning of February, and $33 million is coming in February. So never fear, they're coming in. Direct services is $17.2 million year to date, which is 21% of the annual budget. This is something new that I thought maybe the board would want to see. On the highlight page, it just lists the top three by percentage of budget, what we have spent, which is medication and rehab, which is actually new this year, patient navigation center, and the bridge program. Specialty services, which is network providers, so these are all third-party contracts, is $6.4 million year-to-date, which represents 17% of the annual budget. And the top three on those are dental, ENT services, and musculoskeletal.
Ms. Riley, can I ask you a question real quick?
Yes.
On physical medication rehab, does that involve respite care as well or not?
Yes, so that service, it's the physical medicine and rehabilitative services are primarily working out of the clinical education center co-located with the medical respite facility.
Thank you.
Yes, sir.
Sendero high-risk claims advance for the period is $8 million. So we did send Sendero $8 million in January. Total balance is $13.2 million with interest. And we did have some echo expenses this period. If you recall, we budgeted revenue or a grant from the Ending Community Homelessness Coalition. The budget, I believe, was $1.6 million. They are going to give us $833,000 for over 3 years, and we're in the second year of that. So there's $1.6 million to spend, and we have spent $164,000 of that. And that is my end of highlights. Does anybody have any questions?
Bruce, any questions?
I just have a real quick question on the ending the ECHO monies. Can somebody send me a copy of the report? The agreement between
Oh, you want the
Central Health
contract?
and ECHO?
Yes.
Members, any other questions? Yes.
Can you explain the big jump in cash and cash equivalents?
We're handling deposits in transit differently. We're keeping those in cash instead of keeping those in investments. It's the proper accounting.
Nothing to do with being more fluid in case we need to spend it
No.
down? Okay.
All to do about accounting.
Well, the investments went up sizably too, which I assume was from the bond sales or whatever you
Yes.
call them.
Yes.
Okay.
Members, any other questions? Okay. Yes.
Just a quick question. Are we behind in our projections for certain percentage budget on anything in particular that's of note?
Anywhere in particular? you
Well, what I'm
wanted to-
asking is, from time to time, we've talked about the fact that we might be behind on certain services, and those might be for reasons related to the ability to have physicians, for example, or other reasons. I'm just asking if there's anything that you all noted for this time period.
I would call out two, Manager Kitchen.
Yeah.
Two areas that have been particularly difficult from a recruitment perspective are neurology and psychiatry.
Okay,
Neurology, we have not been able to establish because of recruitment challenges. That's really the sole area that we've not been able to move the needle yet, but we do have a candidate in the pipeline, and we're hopeful that we'll be able to get that service established here over the next few months,
Okay.
if we're able to get an offer executed. Psychiatry is another one that we're lagging behind in, but we've recently signed 2 psychiatrists to fill those positions, and we certainly need that additional capacity going forward, so we're excited to bring those online. So even though we'll see that they're behind in terms of timing in the budget, those will start to catch up as those positions start towards the later half of the year.
Okay, thank you.
Yes, ma'am.
Thank you, members. If there are no other questions, Manager Velez?
Quick one, for future purposes, if we do find, if y'all do find, because you're the one that see that before we do, that we are not current in making those expenditures, can you make a notation for that in our report? So that it's, in other words, we want you to tell us, not we have to ask you. Do you understand what I'm saying? What I'm
The
asking?
answer that we just said for the.
Yes.
Got it.
Thank you very much, I appreciate that.
So if there are no other questions, thank you all very much.
Okay.
And members, I should have said this at the top, but for the Budget and Finance Committee, we have no items that need a vote other than the approval of the minutes. The next item, item number 4, is to receive the January 2026 financial statements for Community Care Health Centers, and Joyce Sloan will be presenting. Welcome. All right, Dr. Yagoda, welcome.
Good afternoon. Joy Sloan, CFO for Community Care, and Nick, CEO for Community Care.
Hi, everyone.
We'll be presenting the January financials. If you can go to the next slide. For January, our surplus was about 1.4 million. We are seeing an improvement in our pharmacy margin this year. I know when we talked about results last year, we were constantly seeing pharmacy margins shrink. We're actually seeing a little bit of a return there this year. So we planned on about a 25% margin. We're running at about a 28% margin right now. So it is driving a little bit more revenue to the bottom line than we thought it would. And that's really because our pharmacy team is working very hard to maximize return on investment in that area everywhere that they can. And as we've reported previously, our Medicaid reimbursement rate is more in line with our expenses. So that's driving more revenue on every Medicaid encounter that we have, so it's helping offset other areas. And we are running under on wages and benefits as we just continue to work to fill open positions and expand access. Next slide, please. And we're currently with a very strong balance sheet. We're running about 39 days cash on hand at about 26.8 million. Our accounts receivables are pretty steady. Month over month, we're not seeing any jumps in that. We are collecting from all of our payers regularly. And our long-term liabilities, we're keeping that at 30 days. We did pay down quite a bit in the month of January. And so our current ratio, assets to liabilities, is over 2.28, which means that we've got more than $2 for every dollar that we owe in the bank, which indicates a very strong financial position. Next slide, please. January had about 1.5 days of closure due to the winter storm. I was in Honduras for that time, so I'm very sorry I missed that. Total encounters are outpacing last year, even with that closure. We've seen about 4,000 more patients at this time for the first 4 months than we did last year at the same time period. Provider utilization is increasing from prior years. That's increasing access. And providers exceeding 90% of their targeted encounters continues to climb. So these are all extremely positive financial indicators of the growth pace that we're on. We still have a few headwinds. Medical provider openings are hovering at about 11%. And women's health and pediatric provider openings, that does affect our Medicaid access volumes. So just a few headwinds we still face. And I think that's it.
You have a question? Were those 4,000 new patients or just 4,000 more encounters?
4,000 more patients than we saw at the same time period. Not necessarily new.
But still,
yeah,
that's
4,000
great.
more.
Thank you. Very good work. Thank you.
Members, any other questions? I was just I had a question about the headwinds, like what's your biggest barriers to the provider openings?
This has been, we've been hovering at this level for over a year now. And as we have grown, that number has held at around between 9, 10, 11%. There's, first off, primary care, a deficit in new providers coming out, new resident graduates coming out in primary care. These are headwinds that all primary care faces, so we're not immune to that. We're fortunate that in the most recent federal legislation, there's been renewal and further investment in health center funding that actually helps support National Health Service Corps and other GME training opportunities within FQHCs. So we're looking at every opportunity to help build out that pipeline. It's largely a pipeline issue.
Thank you. Members, any other questions?
No, you asked about that. And thank y'all for the presentation, not to mention, of course, hard work during trying times, including, of course, that winter storm. But with that said, as related to the headwinds, is there any substantial, when we model, and I guess the first question is, have we modeled what it looks like? And I'm guessing it was just the original budgeting exercise, but what revenue and expenses look like with the medical provider vacancies actually full, and because in some ways it helps, obviously the monthly balance sheet because those expenses aren't there. But if we model it as if it were full, or at least a small, reasonable, whatever typical vacancy rate, what are the implications on the P&L overall?
So just to clarify, to make sure I understand, you're asking about what is the lost opportunity. If we had all of those filled, what would be additional net output, net revenue for us? Is that right?
Yeah, what would be additional net revenue? It doesn't have to be necessarily lost opportunity. I think lost opportunity just encounters like in a vacuum, like as far as the moral imperative is concerned. But in general, if we model this up, looking at a lower vacancy rate, meaning more of the providers were actually hired in, does that have a favorable impact on the P&L or not?
Yeah, great question. And I think I remember you've asked in a different circumstance, what I think is around the similar line. It is a net financial benefit for us to fill every provider position. There are certain provider positions that do not generate a net revenue. So, for instance, our more cost-intensive services like healthcare for the homeless will not break even. They will be in the red permanently. But services like pediatrics, because of our enhanced reimbursement rate through Medicaid, because of the FQHC status, will be a net positive. And so when you combine it all together, our working line is that if there's ever a vacancy in the provider, go get it, fill it, because it's ultimately going to be positive for us, not only on the clinical delivery side, but on the financial side as well.
Really helpful. Thanks for that nuance.
Yeah, you're welcome.
I have one more question. Nick, I'm like a
Yeah,
broken
please.
record.
No, please.
What's the Medicare capture? Y'all still working on trying to get Medicare patients?
Medicare?
Are you still trying to get Medicare patients?
Yeah, it represents about 4.5% of our payer mix. And it's been that level for most of the time that I've been here. And we are building additional strategy around Medicare specifically because Medicare is one of the payers that is most ready to get into value-based care arrangements. So there has been over the last 6 to 8 months some development in our care model and our financing planning to try and engage more Medicare. In particular, how do we ensure that those who are 63, 64 years old continue to stay with us once they cross into Medicare eligibility?
Okay, thank you very much.
You're welcome.
Dr. Iguodala, can you tell me whether, are we keeping track, just curious, are we keeping track of the number of residents once they graduate from the medical school? coming over to, community care?
I can't-
And are we keeping track of that? And whether or not, the second part of that is whether or not there has been a decrease or an increase as a result of us, DMS not participating in any, DEI programs?
Good question. I can tell you subjectively, we've not noticed any
change?
change. And I think probably we are keeping track somewhere of the number of transitions. I just don't have that for you. They've been a very good partner for us in terms of being a pipeline to Manager Rodriguez's question, a good pipelines for some of our core primary care docs.
Okay, thank you.
If I can partially answer that question, Manager, you know, I teach medicine. In the last decade, I've had 2 medical students go to family medicine. 2. I mean, the pipeline, as Nick will know, I mean, there's just drying up, and it's multifactorial why that's happening beyond this board's control and Nick's control, but it's a real issue confronting our society, so.
The reason I ask that is because whenever Dell Medical School comes and makes a presentation to us, they seem to want to highlight, their success. And so I'm just wondering whether or not if there really is a success or not.
Well, Nick, correct me, but I think part of the deal with the med school is they lump a lot of things into primary care, internal medicine, PD, OB-GYN. And most of these internal medicine doctors become subspecialists, meaning the pediatricians become subspecialists. OB-GYNs, although in this country are considered primary care doctors, they really are not, they're surgeons. So I think when you lump it that, but you actually should get true primary care doctors, there's a paucity of them. They're not generating them. It's an economic issue. My students, I think, really want to do good medicine. They're facing a harsh reality of what they're facing when they get out.
I guess what I'm trying to get to is whether or not there is a philosophy and a culture at the medical school of promoting those kinds of experiences so that doctors can so that our communities, our poverty communities, can benefit from that training.
We've always had good partnerships with training programs.
Thank you, members. Any other questions? If not, thank you all very much. Appreciate it. Manager, the next item is to confirm the next Budget and Finance Committee meeting date, time, and location. So our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, March 25th, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. And at this time, I'm ready to accept a motion for adjournment. Second. So having a motion and a second, all those in favor, please say aye. Aye, and the motion passes unanimously. And thank you all very much. We will move on to the next meeting. So members, today is still February 25th, 2026, and it's 4:28 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. And as a reminder, some of our board members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So we will now proceed to the public comment. And there's no one here for that. So we're going to go to item. So, and so I'd like to ask for a motion to approve the consent agenda items C1 through C4 and just leave C3, sorry. Do I have to read them out? No, okay. So I just need a motion to approve the consent agenda for items C1, C2, and C3. So Manager Kitchen motioned and Manager May seconded.
I believe one of them owes the other a Coke. I don't know how the rules are.
Yeah.
I don't,
That's right.
No one called Jinx, by the way, first. All those in favor of approving the consent agenda, please say aye. Aye. All those opposed, all those abstaining, the motion passes unanimously to pass the consent agenda. So we'll now proceed to the regular agenda. And we are going to move to item number 2 on the regular agenda. And members, we're waiting for the county judge to come to present on item 1. So we're gonna move to item 2, which is to receive and discuss a report from the president and CEO, including strategic board alignment, clinical excellence, financial sustainability, and people and community. And Dr. Lee will be presenting. Welcome.
Thank you, Chair Rodriguez and managers. In your packet, there should be a one-page handout that steps through the items that I'll be talking to briefly. Perla, is that what we're handing out now? Perfect, so you can follow on. So today, I'm pleased to share a brief, high-level summary of key updates from our system over the last 30 days. As I mentioned in our last meeting, our goal of this monthly verbal update is to provide you and the public with a clear snapshot of our progress and some organizational highlights. So I'll begin with a few clinical and facilities updates. I'm thrilled to share that this month we've expanded diagnostic capabilities at our Capitol Plaza Clinic with the implementation of FibroScan technology. This is a non-invasive ultrasound-based tool that allows us to assess liver stiffness and fat content without the need for biopsy. This enhances our ability to diagnose and monitor chronic liver disease while improving patient comfort and clinical efficiency. It's kind of on the leading edge of best practice in medicine. Earlier this month, we also launched a new musculoskeletal service line within our clinic at the Clinical Education Center, expanding access to that important component of physical medicine. On the workforce development front, our 6th cohort of medical assistant apprentices began training on January 27th. 8 new team members are now participating in this accelerated 15-week program where they earn full-time pay and benefits while completing their certification through the Austin Community College. This continues to be a powerful pipeline for growing our own workforce centered in our community. I'm excited to share continued progress on our Hancock facility. Several teams have completed construction tours in recent weeks. This site will house our new dental clinic, HIV resource center, same-day services clinic, a new board meeting space. We remain on track to open the David Powell HIV clinic there this spring, with the remaining spaces coming online later this year. Moving to a few updates on system integration and our financial sustainability. First, a very exciting update on our system integration. As of February 9th, the Central Health and Community Care Epic data teams have formally integrated into a single unified department. This new structure will provide consistent system-wide Epic support regardless of where requests originate, reducing duplication, strengthening collaboration, and improving the user experience across our system. A huge kudos to the teams involved in this substantial integration effort. Another great example of system integration, 2 weeks ago I conducted a routine observation visit at our medical respite center downtown, and because of the coordination between our teams, patients receiving care at the respite center are now able to get same-day medication delivery from community care pharmacies. So the CUC pharmacies deliver meds directly to the Central Health Respite patients. This is another strong evidence of how integrating our clinical and pharmacy services improves our care, drives better outcomes, and reduced costs. On the financial side, we've also officially begun billing Medicare for services. Our first batch of claims dropped in mid-January, about 30 claims, totaling roughly $15,000 in new revenue. While that's not a huge financial amount, it marks a very important milestone, and we're hopeful Medicaid billing will follow soon once our pending application with the state is finalized. And finally, a few updates related to our operations, workforce, and community engagement. Though it may seem like a long time ago now, I do want to recognize our teams for demonstrating tremendous resilience during the late January winter freeze. Community Care preserved a significant number of appointments by scaling telehealth services, and our respite center maintained 24/7 operations throughout the weather event. It's a huge thank you and recognition to our staff who ensured continuity of care during this important time. In recent months, we've also launched a new system-wide AI, or Artificial Intelligence Governance Council, to provide oversight of artificial intelligence initiatives across the system. This group will guide policy development, prioritize projects, ensure appropriate use, and help us leverage AI to improve efficiency, operations, and patient experience while avoiding duplication of resources and keeping our information secure. On the workforce front, in late January, we hosted a very successful nursing hiring event at our airport office with 45 total interviews conducted. Within a few days, offers have been extended to 10 candidates. Again, thanks in large part to strong collaboration between Central Health and Community Care nursing leadership. On February 11th, our new Workforce Advisory Council convened for the first time, bringing together engaged staff from across the system to help shape programs, policies, and cultural initiatives that support employee growth and well-being. We also launched our Parents and Caregivers Community of Belonging. This is an internal group designed to foster connection and support among staff with caregiving responsibilities. This builds on the launch of our Women's Community Belonging group last month, I believe, with our LGBTQ plus group set to launch next month. Externally, Sharon Alvis, CEO of Sendero Health Plan, and I recently participated in an Austin Healthcare Council panel focused on coverage, payer strategy, and service delivery. Dr. Yagoda was scheduled to be with us as well, but could not join us because he contracted COVID during the visit to DC. So we did our best to represent the agreed talking points together, and the audience had to deal with me as a poor substitute for Nick. We talked about how those factors shape access and affordability in Travis County. We had a great conversation with healthcare leaders in the Austin area at that event about how we can better coordinate across the region to support our work. On the advocacy front, I want to recognize community care leaders, Dr. Nick Yagoda and Tara Trower, who, with other members of the team, traveled to DC a couple weeks ago for the National Association of Community Health Centers Policy and Issues Forum, meeting with federal partners and bipartisan congressional offices to highlight innovation and accountability in non-Medicaid expansion states. They helped headline of what I understand was standing room only panel to help discuss what might be coming to other states that can be learned from non-expansion states like ours. Last week, we also hosted our second annual Asian American and Pacific Islander CEO Roundtable, or API Roundtable, bringing together about 15 of our community leaders in the API community to strengthen engagement partnership between Central Health and the API community going forward. A huge shout out to Manager Matwani for co-facilitating that discussion with me. Thank you, Amit. And continue to challenge us in how we engage in this space. And finally, looking ahead, we are preparing for our first community conversation of the year, taking place in Precinct 3 at the Oak Hill Community Center. I hope some of you may be able to join us there if you're available. Thank you so much for allowing me the space to provide this update, and thank you again for your continued partnership and leadership in our work. I'm happy to take any questions. Thank you.
Thank you, Dr. Lee. Members, any questions? Yeah. Manager Bridget.
Hi, thank you very much. I'm curious, I just want to ask about the Artificial Intelligence Governance Council. Sounds like this is, well, you said launch, so it's a new thing. I'd like to understand at some point, when you're ready, how you'll be bringing the policies to the board. Because you mentioned policy development, which of course is, policy approval is the board's responsibility. So you may not be ready yet to say your timeline, but I'm just curious what you're thinking. Do you know yet what y'all's timeline is for bringing policies to us? Or
Thank you, Manager Kish. That's a great question.
We're working to finalize the policy draft this quarter.
Okay, so I'll repeat that for the mic.
Okay.
John Morgan and John Clark co-chair this governance council. So John Morgan, our CEO, said we're working to finalize policy drafts this quarter.
Okay.
And we will be bringing those forward to the board for review
yeah,
and
the
approval.
board, I'd be curious too whether it's the kind of thing that goes to the committee, the bylaw and policy committee, but that's for you guys, for you and the chair to work out. So thank you very much.
And Manager Kitchen, I'll just add to that, because that was my question to Dr. Lee on your report. I think what would be helpful too, in addition to the policy coming in a quarter or so, I wonder if your team can also think about any potential board education around artificial intelligence. I think there's a real need for raising that capacity up for all of us, and I think it'd be interesting to make sure that your team gives input about what kind of board education we might get around artificial intelligence, especially with all the resources we have in this community.
Thank you, Chair Rodriguez. We'd be delighted to. Maybe we'll bundle these together, a deeper readout of where we are, together with a presentation of the policies for review.
And if you could add to that, how we're improving our security functions, our policies for making sure that we have less leaks or no opportunities for hacks, things like that.
Cybersecurity.
Yes, cybersecurity, especially in light of a AI, not necessarily human, or
Absolutely,
both.
yeah. So we'll try to fold these together. They are very closely related, as you rightly point out, Manager Valdez. Data is critical, and as we work with different AI opportunities, data security is absolutely critical. So we'll try and pull that together. Chair Rodriguez, maybe we can figure out the right timing together, and we'll bring that forward. Thank you.
Yes, ma'am.
One other quick thing, and you probably have this planned, but it would be useful to have some time between the education and the approval of the policy, because of course we'll want to have the time to see the proposed policy and think about it before we vote on it.
Sure, we'll have in our next one-on-one with Dr. Lee, we might talk about that, because Dr. Lee, this might be an opportunity to collaborate with one of our partners who might have expertise around that, namely the medical school. They might already have someone there, but it's just a thought. But if you all have any other suggestions, please feel free to share them with us after this meeting as well. Yep, Manager Jefferson.
Speaking of partners, I'm curious to know if this hospital district has any access to work-alike type hospital districts, for sharing information, that kind of thing. As you know, I came from the association world and find a lot of value in associating and sharing information. And I know Community Care has access to the FQHC state and national association. So it would be nice to know if well, actually I looked and I didn't find one, but I'm curious to know whether we have some informal work-alike relationships anyway. And it would be good to have similar work-alike relationships with board members from these other hospital districts, because I do believe it's, we shouldn't be reinventing wheels if that can be avoided.
Mm-hmm. It's a great question, Manager Jefferson. So we are members of the Teaching Hospitals of Texas, or THOT. That's probably our closest and most active direct association. We're part of the American Essential Hospitals Association, and we work very closely with the Texas Hospital Association as well. And then informally, we have regular touch points and comparing notes with the CEOs of Parkland, Harris Health, University Health, El Paso in particular. And then relatively recently, I'm forgetting the timing exactly, when we visited University Health. It might have been just before you came on the board, Manager Jefferson, but we took a trip to University Health and met with their board, and actually they provide a helpful session for us, and we can always arrange these kinds of visits in the future as well. And then specifically, the last time that THOT got together, one of the key focus areas was artificial intelligence. So actually, there was direct information sharing around what are we all doing and how do we all sort out. The observation was that there's some real value out there and there's a lot of noise. And so if one of us has thoughtfully, carefully confirmed, hey, there's value here, does that help others sort that more reliably, more efficiently, effectively? So that kind of really collaborative conversation happens regularly as well. It's a great call out. Yeah, thank you.
Thank you, Manager Kitchen and Dr. Marley.
Yes, I think a good follow-up would be to identify and arrange for conversations with board members. We met a couple of the board members from when we went to San Antonio, and it was very helpful. It wasn't the kind of in-depth conversation, though, that's helpful for us at a board level. But that was identified as something we wanted to follow up on. So that's just a to-do to follow up on.
Dr. Martin?
A more general question. What role do you see AI playing in clinical care, management? It's a slippery slope with AI in medicine. That's my first question.
Yeah. Thank you, Dr. Martin. When Dean Lucanetti invited me to join her for a AI panel last year, the headline comment I shared is that for us, we should think of the A as standing for access, and the I is standing for inclusion. Behind that is the notion that sometimes a leapfrog technology comes along where you can go straight to the better way, and it can benefit the poor and the vulnerable and the safety net. That was my experience early in my professional career when SMS texting created a whole opportunity for data transfer in a marketplace when there were no roads, no running water, no electricity, but we could actually run that market and data transfer through SMS. I think that's the threshold we're at now. There are risks on all sides. And so what I can share with you is today we actually do AI in significant ways today. Ambient documentation is probably the biggest win. So the doctor can now not be focused on the keyboard, can be focused on the patient, and the secure HIPAA compliant Epic ambient documentation module does a better and better job in documenting the note that you can then review and sign off. So a huge satisfier. That's nationwide now. There's good evidence that that is like the number one satisfier, and so we're already doing that responsibly. On the Sendero side, as the board may recall, when Sendero went from 12,000 members to nearly 30,000 members overnight, there was no staffing to answer those phones. Call lines are very long. Members are very unhappy. And so over the course of less than a week, they stood up an AI call agent that continues to deliver a highly satisfying service for, I believe, Sharon can correct me if I'm wrong, something in the range of 50 to 60% of the total calls. Somewhere in the range of 50 to 60% of the total calls.
Yes, at least.
Yeah. And yeah, it's not only providers. Thank you, Sharon. It's not only patients, but also providers can check insurance status and validate in real time. And it's saved many FTEs actually without anyone losing a job, but just being an extend service as we grow Sendero. We don't have to grow in the same way we did. And so these are just two examples, Dr. Martin, but I think there are many ways. Language is another huge example. We serve patients from many, many languages. It would not be feasible for us to have a translator service for every language in the API community, for example. However, we may be able to provide very, very good translation in Hmong and Tagalog and Burmese and so on. If we carefully implement. So hopefully improving access and improving inclusion, but doing so responsibly, keeping our data secure.
Okay, thank you. Back to the real world. When is Hancock coming online?
I believe April, toward the end of April, is our target for the David Powell services, some of the convenient care services that TxDOT took with eminent domain. So right around the corner, the team is working hand in glove together between the Central Health and CAC teams. I believe that's the latest knowledge that I have. That will be a careful choreography, but I think it's going well, and there's been a lot of appreciation for Stephanie McDonald's team in particular from all sides. And then the remainder of the services are scheduled for, I believe, December of this calendar year or January of next calendar year, and are also on track, but our focus is on phase one to make sure we can get off the ground in April.
Okay. One last question. Does Medicaid and Medicare pay us an increased rate like they do CUC?
John or Jeff, do you want to pick that question up? I don't know if it turned on, Jeff. Yeah.
Wrong button. Yeah, thank you for the question. Medicaid does not pay enhanced rate, nor does Medicare for, yeah.
Wow. Okay, thank you.
Thank you, members. If there are no other questions, I want to thank Dr. Lee for the presentation. And we're going to move back on the regular agenda to item number 1 to receive and discuss a diversion center update from Travis County Judge Andy Brown. And I believe Judge Brown and Commissioner Howard will be presenting. And then I'll let you all, if you have anyone else you want to introduce. Welcome. And members, just so you know, Elisa May and I, as the vice chair and the new chair, we're visiting with Judge Brown recently, just introducing ourselves in our new roles. And we asked Judge Brown whether or not he had ever had an opportunity to present around the diversion center as an education item. And we thought this might be a good time to just, for him to come and educate us, and Commissioner Howard as well, to educate the board on the diversion center. So welcome.
Thank you. It's great to be here, and I want to thank y'all for your time, and especially for all of your service on the Central Health Board. I know how big the decisions are that y'all need to make, and how hard it is, and how low the pay is for board members in particular. I cannot thank y'all enough for this community service that all of y'all are doing. And Chair Rodriguez and Vice Chair May, thank y'all for having us here today. So we have 6 slides. There they are. And we're going to trade off kind of giving you the slides, and then we can answer any questions. So for the past 5 years, since Commissioner Howard and I basically took our seats on the Commissioner's Court, we have been working to address one of the largest challenges for Travis County, and that is the persistent cycling through jail, hospitals, and the streets that we see in Travis County for residents that have serious unmet mental health needs. And the biggest exhibit of that is the Travis County Jail. So the criminal justice system is the largest expense of the county. The county jail is the single largest line item expense of the county, and it is the largest mental health facility in the county, which it is in counties all across Texas. It's not a good system. In my opinion, the state is not doing what it should do to make that not be the case, and so it's falling to us at the local level to do that. We've got about 2,400 people in the jail today. Somewhere between 40 and 50% of those folks have a significant unmet mental health need, and in my opinion, would not have interacted with the judicial system, with law enforcement, had they had great medical care, all their lives, or at least before they were in jail. A lot of those folks don't have access to health care generally, including mental health care. And I think our teams do a great job in the jail. Our officers, the healthcare workers in the jail do a great job, but it's just not the place to address significant mental health issues. By working across all organizations, I think we can build a smarter system that addresses this need. Slide 2 is, there we go. So this is too big and complex for any one entity in Travis County. Is this still mine?
Yeah,
Okay,
you're
all right.
doing great.
Thank you.
Keep going.
And so that's why when we started this work in 2022, we brought together stakeholders from across the county, from across the government, from the private sector, and others to help think of good solutions. This work included working with law enforcement, healthcare systems, the city, the county, the state, our justice systems, and community voices. Each of us has a unique statutory authority and responsibilities, resources, and expertise to bring to bear to help build a better, smarter system for serving people in our community outside of a jail setting. And again, I want to thank y'all for all of your work and your time that you're putting into this, and I'll hand it over now to my colleague, Commissioner Howard.
Thanks, Judge, and thank you again for having us. It's been a while since I've sat in this seat, but it feels really good. There's folks around your dais and in this room that have been working together with us and members of the county for a long time to better serve the folks that we're talking about today. And the groundwork has been laid with our partners. The last slide talked about it. You can go to the next slide. Back in 2023, we asked the medical school, Dr. Strakowski, to really lead the discovery about what can we do better to address this suffering really that's happening for people cycling in and out of the streets and hospitals and jail. And there were 5 things, and on our slide, you can tell that together, we have already made real progress on some of this work. Counsel at first appearance was one. That's where we make sure that folks that are brought to the jail, that their rights are immediately addressed and they have an attorney look at their case before they just sit or get sent their freedom removed. Second, we haven't made as much progress, but because it's really hard, and you know this, and it's about data sharing and technology resources and improvements. That's data sharing between Integral Care and the county and the jail and ECHO and our partners, so that we can have, that you can have, that the doctor in front of the patient has a holistic view of where all these clients have been, and so that we know who is it that really needs what. How many days and nights are these folks in the jail? What are their diagnoses? What are their labels, if you will, that we've put on them? What are they in there for? And so sharing this information will help us better serve these folks. And we are making progress on that. Dell is sharing that with us and with our partners and with the folks that we've hired to help us make progress on the diversion center. We've worked hard with the nonprofit community, and thank you to President Biden, who sent money to the communities after COVID to help build more supportive housing. And we have a slide to address that. To expand peer programs. Every diversion center we go to, every substance use program that we see, it's the first person that contacts a client is a peer. And that we've added more peer support. I think y'all are funding some of that in this community, and it matters. The 5th one was to build a diversion center. And we've spent 2 years going around the country with Pat Lee and Jeff Richardson from Integral Care and staff, looking at what are other communities doing? How are they addressing this? And I think we're starting to coalesce around what are the key components that we're missing in our community so that we can build out an integrated system of care and the continuums, the systems that we need. Another big piece was a steering committee. We wanted people to commit to this exploration with us. And we've held lots of meetings with leadership from all those community organizations on the slide before, and identified priorities and problems to address. And they're listed out here: to increase crisis inpatient bed capacity, including facilities for involuntary commitments. We have very little of that, and it's a tool that best practice shows we need to make sure we have to help folks who need that kind of care. We need a no wrong door place so that law enforcement and first responders can bring folks who are in crisis 24/7. And that's just clear. We're doing more of that in our community, but that's a goal. And a standardized triage and intake process. This needs to be simple for first responders and clear to the community where to take someone, and that everybody gets equal access to triage and care. Another big piece of this is that the county stepped out and hired consultants. We did an RFPQRS or whatever, and put together a really strong team to work with our community partners to take work that like Del Med had already been doing on our behalf, to see what the scale and scope of this entity would look like. And so we're knee deep in that work right now. Phase 1 is about 50% complete, and we expect that this summer. And that's just sort of looking at, what is the conceptual design? What services would be offered? Who would do what? And how do we get the care that we know these folks need actually delivered? Phase 2 will include architectural and engineering documents to actually build the diversion center. I think I'm still talking. Or is it your turn?
Slide 4?
Yep.
Okay, you're on slide 4.
All right. So The building our collective diversion muscles and expanding supportive housing capacity. So what we've done so far is to pilot what we think we're talking about. And again, the city and the county and Central Health, some of us put in money we had from the federal government. Some of you put in money through your service provision of healthcare. But we've been able to launch a pilot led by Integral Care to sort of see how this could work. And the first thing we did was expand their psychiatric emergency services. This has been a facility on Airport Boulevard in our community a long time, but because of funding, it was not open 24/7, and it did not have enriched, like, medical provision that whole time. And so people had to wait, or it wasn't open. And so with some of your funding and ours, that has now been we've expanded those operations. And you can see there they've served 1,000 clients. It's taking referrals from emergency departments, the Sobering Center, Integral Care, law enforcement, and central booking. And the outcomes are really good. People that are served at the psychiatric emergency services don't get arrested again. That you can see the data, 93% have not been rearrested in 30 days, and 77% have not returned to the emergency room. Those are good numbers. Another piece that I was most excited about was something new. We knew that people needed a longer runway to get better. They might go somewhere and get some meds. They might get released from jail with one pill or something, but they need a longer chance to get housing lined up, to build a relationship with a physician and get set. And so we created this sort of fancy shelter where they can stay for up to 90 days with a lot of therapeutic wraparound services. And there I know we have doctors coming by. I don't want to start listing who I think's funding all of that, but it's, Community Care's involved, Central Health's involved, Integral Care's involved. We've all been working together. And again, the outcomes are even better, as you can imagine, because this is taking folks that are referred either from the jail or central booking, or some that are at psychiatric emergency services, and we're able to start working with APD so that they take them there and not to jail. That's sort of the real goal here. We call that deflection. And so we're doing that in the city-owned facility that Integral Care leases that's on 15th Street. It's an old Ronald McDonald house. And the third sort of sweet spot to all this work we've been doing, again, is building out more permanent supportive housing so that we have a pathway from the diversion pilot, if you will, to safe and decent housing. So it's sort of looking at the holistic picture. It's bringing healthcare, justice, and housing continuums together and really trying to meet the needs of this particular piece of our population that needs, your provision of care in a way, and trying to meet that need.
All right, so all the work that Commissioner Howard just described is to help us figure out what we need to do in the community. Look at some results like she described. How do we best help people access mental health care outside of the jail? And got a few of our takeaways, and then I'm gonna get to the ask, and then we'll be done. So our key takeaways are, first, that we need to both do deflection and diversion. So Commissioner Howard mentioned deflection is pre-arrest, diversion is post-arrest. So we need our community to have those options. Our community will be safer and better served if people who need health care don't have to go through the county jail to get that health care. But if they do, we need to have some systems in place to identify them and connect them to care either way. 2, it needs to be 24/7. It has to be easy for law enforcement in particular, and also first responders to use. It should be easy for them to drop off, and then the healthcare experts can help navigate the appropriate place to go. So one central intake area, and then that isn't just the jail, but lets people go to healthcare or to the jail if needed. We need to be able to stabilize people who are in crisis so that we can hand off to lower acuity care and outpatient services. And for people who need a higher level of care, we need to be able to have those beds, those inpatient beds, and to be able to take involuntary commitments. Some individuals cannot be stabilized in a crisis bed alone, and we don't currently have much of this ability in Travis County. And as I mentioned before, the state hospital system, as I think we all know now, is overburdened. There's long wait lists. It's not a resource often for us. So we need to help people get through this complex system, and this overall will reduce the burden on our system. It will create better client experiences and get better outcomes. So here's the ask for help. For right now, until early summer, our design team is working to evaluate different sites for where we could put the diversion center. And the diversion center could be just like the thing on Airport Boulevard that we're currently doing, but also with some sort of involuntary psychiatric hospital piece that goes by different names around the country. And the question is, do we put that all in one place? Do we put it in two places? What is the exact solution? That's what the design team is helping us figure out. But to get this, we need to make sure that, there's the ask, sorry. Okay. So they're going to develop a conceptual design for what I just described. They're going to help refine planning elements like who will be served, what services are needed in that thing that we're building, how much space do we need, and operational expenses. And they're doing this work along with our community partners here at Central Health, with Integral Care, with Dell Medical School, with law enforcement, and others. And then through the end of 2026, we'll need to confirm our partner commitments for funding, ownership, operation, and governance. And very specifically, here are those asks. We would like you, this board, to include the diversion center as one of its strategic priorities as you plan your work for the next 5 years. We would like you, this board, to partner in the financial contributions for construction and operations of the center because mental health care is health care. And then third, and finally, to identify a parcel of the Brackenridge campus that could be evaluated as a potential site. It's not necessarily, you're not giving us land in this, you're just letting us evaluate a potential site location for the diversion center or a piece of it on or a future mental health campus. So again, thank you so much for your time. Those are the three asks that have some urgency with them. And Jeff, you want to say, am I handing it over to Jeff?
Let's see if they, we don't have much
Okay.
time, so
Yeah,
let's see if, do y'all have any questions you want us to try to
Yeah,
answer?
so Jeff obviously is a huge partner, and just as Central Health is in all of this, and knows we had the good opportunity to visit his previous employer up in Baltimore this week and to see the great things that he had created there. But want to open it up for questions if there are any.
Thank you. I know Manager May has a question, and then Manager Kitchen has a question, and Manager Valadez has a question.
Thank you all for being here. We appreciate it. We certainly want to be your partners as well. My question is, how much money do you think you're going to need from us as we're beginning to think about our budget moving into the next fiscal year?
Good question. I don't know, and I don't think we would know until the community agrees on a design on exactly what's going to be in the mental health diversion center. We're not asking you to do this alone. The county is putting up funding as well. We have some funding saved for it and some ongoing funds dedicated for this purpose. But there's not a dollar amount that I know right now, Commissioner
Yeah,
Howard.
I think we want to be able to come back to you in 8 weeks. That'd be 2 more months. We're closer to summer, and we are hoping that there's a little more shape on it, soon.
Okay, very good. Thank you.
And if I could add to that, first that Pat and his team has been amazing to work with. We've been working with UT as well as a partner to really think through clinically what are the best tools out there. And part of the funding strategy is also looking at what are the ways that we could ensure sustainability with this. And so Judge Brown mentioned the inpatient components. And again, how could we draw down other dollars into this community in addition to what we already have to be able to both build it and sustain capacity and be able to provide the clinical needs so that people aren't cycling through. And one of the important lessons learned that Commissioner Howard just mentioned is really that 90-day, that length of time that we're able to see someone. We're able to wrap around a lot of clinical supports to these guys to help them get to a different place. And that's foundationally, one of the challenges we're having is people will get discharged from the hospital at an acute level of need and need this level of support. And so the financial model is also driven by the clinical model and a sustainability strategy. And I won't bore you with that today, but there's lots of work that this team's been doing across all of these different organizations to make that happen.
Manager Kitchen.
I wanted to say thank you guys for being here, and also thanks for working on this. You know, it takes persistence over a multi-year process, and it's very much appreciated. And very necessary. I think I see the necessity of it. I'm sure my colleagues do on the board also. So my question is, or actually it's not a question, I think your third ask regarding identifying part of the BRAC site for evaluation, I'll look at Dr. Lee. I think we may have already begun that process with you all so your consultants could take a look at that. Is that correct, Dr. Lee?
That's my understanding, yes, Manager
Okay.
Kitchen.
Okay, excellent. So you can check off one of the asks.
All right, as long as we're getting some mixed signals, I gotta say, from staff.
okay.
So if y'all are all on board with that,
Yeah, I think
great.
so.
Okay, you are the board. Okay, all right. It's good to hear that from y'all. Thank
Yes,
you.
because I'm
Okay.
understanding the ask was to identify part of the BRAC site to evaluate.
Right.
Correct.
Yeah, so
Okay.
Chair, I think we're all on board with that. So, okay. And then, in terms of the dollar amount, it sounds to me, I just want to confirm, it sounds to me like your timing would fit with the timing for our budget cycle. If you're talking about having a better idea in maybe 2 months, that's around the time that we need to be thinking about the dollars for our budget. So just wanted to provide that feedback in terms of the timing.
Thank you.
Manager, all of this, and then Dr. Martin.
Thank you all very much for being here and for allocating your time and energies into this way long past due effort. My concerns, the populations in the homeless world that are most worrisome to me are the children and the elderly, because those are the ones that tend to drop off. And with the children, I noticed that in your listing of all the organizations and entities that are working with you, I didn't see not one school district. And we have 17 school districts in Travis County. And Integral Care, the old MHMR, has historically been the entity to work with parents and children who have the mental health component issues within the school, their school age. So that would be from the time they enter, could be at age 3 up to age 22 in Travis County. Okay, that's a long time for them to be in the system. They also go through the city, through the juvenile justice system. And at that point, the judges who are going to be reviewing their cases and dealing with the kids many times, because I have been there and witnessed this, they do not have parents that are with them. They're alone. They may not be fluent in the language. And so there's no guardian, there's no adult, there's nobody there, and there are decisions being made as to where to put them. And that has been something that from way back in Judge John Vasquez's day, that he drew attention to that and got the city and the county to address that. But that hasn't improved. We still have children dropping through the cracks. And normally you see the increase in between elementary school and middle school, or middle school and high school, and then they, if they make it to graduation from high school, well, we're lucky. But most of the time by then you're going to find them in the streets. And so since I hate to use ICE, Integral Care, I guess I'll just use Integral Care. I think that was a very poor use of I guess an acronym for them in light of everything else we're dealing with ICE. Those case managers, those school systems, all have the school staff, and the parents work with the parents and with the Integral Care's staff they have all that information already with you, including the judge if they're regular truants or this or that or the other, or they're even getting put in serving some time. So that's a way to cut that population down because you're dealing with a finite population. With the elderly, I'm finding that many of them are co-locating. You may have 3 or 4 different households in a 1, 2, 3 bedroom apartment because rather than living on the streets, if they're a unit, they don't want to be in the streets. They'd rather be in the car. And there's still people who are living in cars, but I just think that it would be a good idea for the school systems to be brought in and force them to share that information, which they already are doing. Because if you have a child that's going into your municipal court or your county courts, because they go to the county also, they will have access, those judges will have access to all that information from the schools to be able to pull that and give that to this team that could maybe be working with a specialized population. I personally would be 100,000% supporter of you all getting the money and the locations. I'd love to see something like that happening at the Brackenridge track since we don't have the hospital there anymore. And that's pretty centralized, but I don't know whether that would be a good use for the public land at that time. I know, so whatever you want from us, please work with our leadership team and tell them this is what we need, and I'm sure Jeronimo and Elisa would make sure that got put on the following agenda item for funding, and not have to wait 2 and 3 and 4 months for next quarter for something like that to happen. But anything that we can do to provide information and services or connections, please let us know. And I'm especially concerned about the non-English population also, because they also tend to fall through the cracks.
Thank you very much.
And
Thank
Cynthia, just to echo your sentiment, I think one of the things that, again, this has been I said this the last time I came in front of you all, is that we've really had a great working relationship with everybody in this room, from the central health team to the community care team to the county, all around these issues. But I think one of the things you brought up, which is important, particularly when we're talking about children and adolescents, is prevention and early intervention really does alter the arc of some of these higher needs going down the road. So part of the work as we envision this is, this community has a huge need for treatment for children, adults, seniors, and doing this, as you heard Commissioner Howard just made you a doctor, by the way.
Sounded good.
Really is to be able to start treating at the right place at the right time and have some inpatient capacity that is involved in intervening with this collective population. The schools where we're working in has told us this. Our teams are working and doing this. Community care team is doing this, central health. But I think that is a huge need in our community, having that ability to have inpatient capacity. There's kids now boarding for days in hospitals because there simply isn't sufficient bed access.
Thank you.
So thank you.
Dr. Martin and then Manager Matwani.
Thank you. Coming from years of work in the Parkland and Bracke ER, I really want to thank you for the wonderful work. It's incredibly important. I do have a question, one question, one comment. One was, I'm assuming you've done a demographic study expecting what the demand will be and before we start to build something? Because it's gonna do like that.
Yeah, part of the work that we're doing, and some that Strakowski did in his extensive work with us in 2023 involving y'all and others. We're also working with the medical school to look at who's in the jail today and to, extrapolate from there basically like what services would be needed to make sure that whatever number of those people with unmet mental health need in the jail aren't there tomorrow because they're getting mental health needs. So, yes, sir.
Okay. One other question on the Brackenridge track. We had just a thought. We had a economic analysis of the dirt, and it's worth almost $500 million. And so I'm wondering for this board if that's the best use of money. This is a recurring problem with Central Austin properties. I mean, the State School off of 35th Street, et cetera, where, so just a thought to consideration, not
Absolutely,
not to
yeah.
neglect the demand, which I completely agree with, but to sort of what is the best use of the resource we have, so,
I think that's a great, very fair point. Yep.
thank you.
I think Dr. Martin is asking what the Health South property is gonna be doing as well, but, Manager Mawani?
I like to joke at the office whenever I look in the Zoom or see too many people in the room that it's an expensive meeting. This is an expensive meeting, and I really deeply appreciate y'all being here in person. I know your doors are always open to us. You always reach out to us to make sure we know that we can speak with you all. But it's humbling and inspiring that y'all would come directly to make this presentation. That's even quite technical, and that's even pretty.
We didn't do it.
It's pretty motivating as well. But you know, with that said, it does seem like the imperative is to stop what is effectively, you know, when I was speaking with Pat about it, the criminalization of mental health needs. You know, the place to get treatment for that is in the jail, and that's super meaningful to me. There are a couple of points I would like to make. The first of that, you know, this is thoughtful, it's evidence-based. Clearly, it hits the dual bottom line of the moral imperative as well as the pragmatic imperative, doing the right thing, and then, of course, doing so in a sustainable way, doing right by taxpayers and patients. And I think about, you know, there are a couple of things that come to mind. The first of which is, you know, these pilot results that we've seen. Is that just effectively an empirical example of how Central Health and Integral Care are working together and doing this
Right down the
now?
road, yeah.
Right, yeah, so
And community care, you know, everybody.
and communicate, yeah, but this is how these partners are working together and doing, okay, so that's super meaningful to be able to come back and bring that data. The second thing, speaking of data, and you know, some of us can't get enough of it, and I know y'all are steeped in it, and you probably had the 10 times more technical presentations, right? And I may have even missed some. Or maybe some of this doesn't even need a napkin for the math, like it's just so obvious. But it would be helpful for me to understand the econometrics, and if y'all could point me to whom I should talk to, if it's staff or not, but understand sort of in the jail population, you know, maybe 40% have a mental health designation. You know, what is severe, mild, or moderate? You know, what does that flow look like as far as cycling back into the system by means of recidivism, what have you? You know, and then where are the potential intervention points like reentry, and how does that mitigate that, and what is the cost along the way? And that helps for me contextualize what's the following point, which is, you know, really guidance around sustainability and partnerships, right? Like, and y'all with all those logos up there definitely make, I think at least some of us, but certainly me, feel a lot better about this being a coalition effort, particularly with key public entities involved. But, you know, and y'all even mentioned it, for me, and I'll just, you know, flag this for Chair Rodriguez and Vice Chair May, navigating the statutory, like, sort of mandate, what our statutory mandate is, and ensuring that we're not cannibalizing another area, either by means of mandate, which again, all health is health, right? Like, or by means of community need, whether it's, you know, physical versus mental, you know, what the patient demand is and what have you. And guidance on that navigation is going to be important, but also understanding like what the public entity coalition is going to look like possibly in the long term. Y'all have a much stronger bully pulpit when it comes to being able to influence, I think, other public entities. So I just want to flag that as well. Again, thanks so much for this.
Sure.
Thank you very much.
Just, if we don't have time to nerd out today on the data, but we could, there's a lot of data from the Diversion Center pilot that we'd love to come back and share with you, and it answers some of the questions that you had. But one of the ones that we spoke to here already was there's a group of folks that have such acute needs that they're literally routing directly to jail. And so we need to be able to, when someone is in that level of acute need, and in terms of diagnostically, we'll be able to share that information as well. There's a significant gap in our community with acutely psychotic folks that are not getting the length of treatment in an inpatient setting to allow them to not repeat that cycle.
Yeah.
And that's a foundational piece of this around deflection and diversion that really will change things dramatically for us.
And so that's really helpful. And then when it comes to like current community conditions and what the costs of inaction are, it's really helpful to me, because if we see that, okay, this cycling is costing 30 million, or 70 million, then if we're talking about another dollar amount, I can be like, well, bro, I mean, compare it to the counterfactual and deal with it, and that kind of context is really helpful. I know it's out there. Sorry, I'm asking for it late, but I would love to chase it down if you could.
Yeah, we can help with that. I mean, there's obviously just the costs of somebody sitting in jail, but like you're saying, the other costs surrounding that, I know we have numbers and we'll get those to you.
I think Manager Jefferson had a comment, and then I have one, and then I think we're.
So, as more information is developed for evaluation and so forth, and this probably is mainly for Dr. Lee, but I see two different buckets. There's a whole set of analysis and I guess conditions that need to be met for the construction or land use, and then construction and operations. On the operations side, I get the impression that Central Health, either directly or through its partners with Community Care and Integral Care, obviously, is already committed to some kind of financial contribution for this health need. And so to see what the operations ask is, what that is versus what we're currently doing, and then what the increase would be.
That's a good point. Thank you, Senator.
And just to pitch what Pat and I talked to you all about a while ago, and was that we are working together hand in hand with this to try and coordinate these efforts in a way. And I think that there is a lot of work that we've already started, and foundationally, I think it'll help us build on this.
Thank you. Judge and Commissioner Howard, first I'd be remiss if I didn't say thank you for approving our budget and our tax rate. Because I think that's really important to understand the role you all play. I think the other thing, and I think we've talked to both of you all, and just for the board's knowledge as well, I think this is perfect timing for them to come and talk about the Diversion Center, because one, the board priority so far is obviously always the budget and the budget process, which Dr. Lee and his team will go through that process with us, and where the question is where this goes. I think by the end of the year, we've also communicated that we will have a comprehensive facilities plan, which allows us to be good partners around our knowledge of the Brackenridge tract and the other facilities that we have. The other one is that I know Elisa's chairing our strategic plan that will cover all of them, and working with the administration as well. And we've passed a resolution giving direction around the strategic plan. And then the last one I think that Dr. Lee has and the team has brought to us is the fact that we are doing a community health needs assessment focused on individuals that are 200% below poverty level specifically. So we will have more granular data ourselves around all this. So like I said, thank you all very much. I know thank you for the partnership with Integral Care as well. But I wanted to mention all that in the context that this board is engaged and involved, and there are ways and opportunities for us to be even more integrated in a system of care that is really centered around the individual with the need. Unless there's any other questions?
Just one, very quick.
Yes, ma'am, quick one.
Quick point. If there was a way for you to put the numbers together for this budget session, so that we as a board can look to see, since we are being faced with some heavy-duty options coming into this budget session, I personally, we as a board have to look at what our priorities are. This, to me, is an immediate priority. And if we had a hard number for what we're looking at, it would go a long way with, I think, helping us to make decisions, strategic decisions, on how we're going to spend those monies when we're looking at what we have here and resources availability. or what we can ask for to cover something else, or else hold off on making major purchases for this as opposed to dealing with that. So if you could do that, I'd appreciate it.
Thank you.
Thank you.
Yeah, so, and I think this is the right time, like, just a little bit around the country, we're not the first people to do this. We're kind of in the same timeline, I think, as Salt Lake County and Salt Lake City is. Lubbock is ahead of us. Nashville is ahead of us. Miami is way ahead of us. So this isn't necessarily new stuff, but it does seem to be something that counties across the country are wanting to do. Dallas County is wanting to lean into this more. So thank you all very much for your time. And Board Member Jefferson, that is a very good point. So we'll take that away and see kind of what is being done now that maybe could be done in this thing that we're creating. We'll get you numbers about costs generally. I mean, everybody, we'll get this to everybody. And then we'll make sure, Dr. Martin, that we're looking at kind of who we are exactly serving and based on who's in there today and what our projections are for the future. And we'll get you all that information. So thank you all very much.
Thank you.
Thank you.
Thank you for your work.
Thank you. Members, we're gonna take a 10-minute break as our food is here. So we're gonna take a 10-minute break and we'll be right back. Members, we're back from a break. It's now 5:52 p.m. On February 25th, 2026. For members of the public, I just want to go back for 1 minute. I had mentioned earlier that we would have public communication at 5:30 p.m. And we have had no one sign up for public comment, but in the interest of transparency, I just want to ask if there's anyone in the room from the public that would like to make a public comment. Okay, and if not, we're gonna move on to item 3, which is to discuss updates and board input about East Cesar Chavez neighborhood concerns regarding unhoused individuals and the Central Health Administration's response to those concerns. And I think we have Dr. Lee and Ted Burton presenting.
Thank you, Chair Rodriguez and managers. So I'm going to just share some updates with the board, many of which have been provided both in an email and a memo in the packet. So I'll cover some material, and then our Senior Vice President, Chief Communications Officer, Ted Burton, has been spearheading this effort and is here to answer any questions you may have. So just to catch us up, during the public comment period at our January Board of Managers meeting, we heard from a number of our Cesar Chavez neighbors, many of whom are members of the East Cesar Chavez Neighborhood Association, about public safety concerns related to unhoused individuals camping around our building. These concerns are real, and this is a difficult and emotional situation for many of our neighbors. Central Health's mission calls us to care for our most vulnerable community members and also protect public safety, and we are committed to doing both. That said, we know there is no silver bullet to this challenge, and it won't be solved overnight. And so today, I'm pleased to share an update on the work our team has undertaken since our last meeting, along with our planned next steps. We've assembled an internal strike team to coordinate our response, led by Ted Burton, as I mentioned, working closely with our community engagement manager, Yesenia Ramos. And this cross-functional work group includes colleagues from government affairs, infrastructure, healthcare delivery, healthcare for the homeless, communications, and system integration. So this is really a cross-functional team. Together, this team is coordinating the following actions. First, we have increased security. So we've worked with our security contractor to expand their presence here at our Cesar Chavez office into the evenings and weekends. That began on February 6th, Friday, February 6th. Security is now on site 7 days a week from 7 a.m. to midnight. They're conducting regular perimeter patrols, monitoring our security cameras from the front desk, and are ready to report suspicious or inappropriate activity as needed. Since we have implemented these extended hours, we have gotten positive responses from several neighbors, noting this change has helped the situation from their perspective. Second, we've been expanding our outreach. Our Medical Bridge mobile team is piloting late-day visits to connect people experiencing homelessness in the area to housing, health care, and other support services. They made an initial visit the week before last and engaged with 3 people. 2 of them had been seen by Community Care for services before. All 3 individuals are now scheduled for follow-up visits with our team. Third, we've been coordinating closely with our partners. Austin City Councilmember Jose Velasquez convened a call on Friday, February 13th that brought together Central Health, the City of Austin's Homeless Strategy Office, Austin Police Department, Austin EMS, Austin Travis County EMS, Austin Resource Recovery, City of Austin's Facilities Department, and the Austin Public Library. There were nearly 20 participants who joined together to align on next steps, and our team outlined the actions we have taken to date and reaffirm the full support of our board and executive leadership. This group has a scheduled follow-up meeting with several neighbors representing the East Cesar Chavez Neighborhood Association leadership on March 11th, and our staff will be in attendance. To move people off of the street in a meaningful and sustainable way, ECHO underscored the need for coordinated assessments. Understanding who is at this location, what they need, is essential to creating clear pathways to supportive housing and long-term stability. Did I miss this? No. Okay. And fourth, improving sanitation efforts in the area. So we are continuing daily litter pickup on our property to reduce immediate health risks. Our landscaping contractor is assisting with this, and we are engaging our vendors to help with biohazard cleanup when needed. We have contacted Cap Metro to request better maintenance of the bus stop directly in front of our building. And finally, we do recognize that a strategy around trespassing enforcement is also needed. We're working closely with the Travis County Attorney's Office on this component, and we'll share updates as they develop. And as you'll see in your backup, a couple weeks ago, our team sent a letter summarizing these actions directly to the neighbors who provided public comment, reaffirming our commitment to stay engaged with them on this issue. Since then, we've received several messages from several of the neighbors who provided public comment, noting that there is a much stronger sense of safety in the community since no one has been camping in the parking lot since our extended security hours began. Yesenia remains in close communication with all the neighbors and will continue to monitor additional feedback and concerns. As these actions are implemented and as we further flesh out a trespassing enforcement strategy, we will keep the board informed, of course. This is a complex issue that will take some time to address, but we are committed to ensuring public safety while remaining steadfast to our core mission. And as I mentioned, both Ted and I are pleased to take any questions or comments from the board. Thank you.
Members, any questions?
Yes.
Sure.
Dr. Lee, can you tell me what the, or maybe I didn't hear it right, what were the next steps that came out of the meeting with the city?
Address that. Thank you.
Sure. So we have a meeting scheduled on March 11th. The meeting that Pat referred to included all of our partners, and we have the list of all those people, about 20. Thank you, Alicia Ramirez, who's in the room. She is the one who helped us work with Councilmember Velasquez's office to get that meeting scheduled.
Okay.
And then we have another meeting scheduled on March 11th that will actually include neighbors as well. So that's the next key step in this process.
Oh, okay, so in terms of next steps with the city, that's pending having that meeting
Correct.
with them. Okay. I think I had mentioned before, just something for you all to be aware of and consider is that this area was the first site for HEAL, or at least the area in front of the library. And what that meant in practical terms was that there were living places available, units available in Southbridge for folks along there. And then afterwards, the area was supposed to be kept as an area where there was no camping. So I think it's really important to remind the city of that commitment to this area. And so now, technically that was not our parking lot. It was just the area in front of the library. But it's still surrounding area. So I do think it's important when you talk to them to remind them of that commitment. And of course, they probably don't have enough places at Southbridge, which is the shelter for everyone who may not be as familiar with it. But I think it's worth reminding them of that, and perhaps, if necessary, making sure that this area is on the list for units at Southbridge.
And
So-
you shared that with us in
Yeah.
advance, so thank you for that. And
Yeah.
it was a very robust conversation about many of the challenges that all the partners face. And it was also eye-opening to learn just all the things that are currently happening at this location in terms of Monday morning cleanup by City of Austin, library staff, and Austin Resource and Recovery was there, I think, also to talk about mitigation in terms of litter cleanup and hazardous waste cleanup. So there's a lot happening. And I think it'll be good for the neighbors to hear directly from these partners at this March 11th meeting. So I feel like we're making progress, and we started by saying there's, as you all know better than anybody, there's no silver bullet for this.
Yeah, I'm sorry, Ted, I didn't mean
No,
to interrupt. But
that's
the
it.
bottom line is they need a place to live.
Yeah.
And we can do all kinds of other kinds of stuff for folks, but until we offer them a place to live, then it's not going to take care of the problem. And that's not, I'm not saying that's our role.
Right.
I'm just saying that's my message to the city, and to other partners. It's unless you offer them a place to live, we're going to have an ongoing issue here. So that's the point I wanted to make.
Yeah. Thank you, Magic Kitchen. And we will ensure to lift up the HEAL Southbridge beds in the next conversation. And thank you for your leadership on this issue.
Thank you, members. Any other questions? Manager Wallace?
Well, that's my neighborhood association now since we merged with Holly. And this has been going on for decades and decades and decades. Until we get rid of the soup kitchen, you're not going to get rid of the of the problem. Sorry, you're not. The soup kitchen remains there. They keep getting their lease or allowed to be there. The problem was the terrorizing of some of the kids that were trying to get to school. So they had to come up with alternative routes for the kids to get to Sanchez that lived in this neighborhood back here across the street. And the issue remains there. You know, they think that they're making a dent, but I see this every day. And now we have a new location that's created about the 2000 block, 1900 block. There's a house that's got next to that Coco, whatever it is, you know, it looks like they have Halloween costumes or something. But in that, I think in that same block or the one right before it, there is a congregation of at least 20, 30, 40 people every day, all day, in front of that house. And they're sleeping on the street. They're sleeping not on the street, on the sidewalk. And nobody wants to walk through that neighborhood anyway, or through that block, because this is expanding. It's going from here, it's going further, until, I think they pretty much got, yeah, no, it's going deeper into the neighborhood, and they may have taken care of what was happening under Montopolis Bridge. So it's this whole section, and so long as they've turned Cesar Chavez into a bar destination, you know, that was a big draw. People think they could come over here and panhandle or whatever, or else look for targets, marks, but we still have a problem. And I'd like for the city to tell us what they're gonna do about that soup kitchen getting moved. It's not only a matter of where are they gonna go, that we eliminate the soup kitchen from the intersection of Cesar Chavez and 35. That, you know, and it's only 2 lanes, 1 lane going each direction. You got traffic that's a mile down the street and going and coming, you know, on Cesar Chavez. Y'all may not necessarily travel Cesar Chavez, but that's what happens. And just wait until the development, the increase in density of the development occurs. It's going to be a lot worse. But, you know, my heart goes out to anybody that's on the street that has mental health issues, that has this, that, the other, because those were populations that the city ignored for the previous 150 years or 100 years. They didn't care. And now we've got to deal with this situation, and it's going to be tough for anybody who buys in this neighborhood. That's why we were number 1 targeted for gentrification, because, you know, the families that were living here just couldn't stand the quality of life impact on them. So it's sad, but I'm thankful to Central Health for all their help in helping the neighborhood try to neutralize the impact by the homeless population. But again, these are issues that were created. They were created, and it's going to be very difficult to get a handle on them until they address where are they going to eat, where they're going to sleep issue.
Thank you, Manager. Any other comment? Dr. Martin?
I'd like to state that these people are not problems, and the soup kitchen's not a problem. These people have to eat, they have to sleep. And I think if we start putting a not in my backyard kind of mentality to it, I understand the neighborhood's incredible frustration, but I think it punts, and I think we need to continue to forcefully advocate for housing for these people. To move a soup kitchen, where are they gonna move it to? Where they're gonna eat? This occurs at the South Austin homeless shelter. It's the same issue with this elementary school right across the street. It's a dilemma, and I hope we don't think of these people as a problem. They're humans who need to eat and need to sleep. And I think if we persist in that attitude, to advocate for their well-being, understanding the dilemma of the neighborhood, but that's not a changeable situation versus advocacy can continue vociferously from this board to change that.
Could I say something?
Yes.
I think every one of us really cares about these folks, and I thank you, Dr. Martin, for reminding us of that. I think we all do. And I also agree that advocating for housing is really what we need to do. I don't think any of us are saying not in our backyard.
That's for sure.
Some people do that. In some neighborhoods, I've seen that happen, but for the most part, it's not. In all the work I've done with the city, that's not what people are saying. What they're saying is, look, it's not humane to let folks stay on the street. And we all really need to come together and put our commitment behind getting housing for folks, housing. I don't want to sidetrack us a whole lot, but I just really felt like it was important to say that.
And I'd just like to clarify, last comment, that sure as heck wasn't what I intended to be garnered from the words that I used earlier. This has been a population that I have advocated for my entire life, for as long as I've been here in Austin and in East Austin. Even when I didn't live in East Austin, I was in South Austin. And so the issue is not a neighborhood problem, it's a societal problem. And the city of Austin did not care where anybody was located so long as it wasn't in their neighborhood, north, south, and west. So they didn't care that they came east. And that is the gentrification issue that the city, known at one time as the most segregated community in the United States, here in our neighborhood that we're located right now. And they didn't take care of it. They said it was okay for us to have all the dump sites, all the industrial zoning, everything else happening. And this is what happened because nobody cared. Let's put everything here. Let's dump it in our neighborhood, okay? Because they didn't care about the quality of life of the residents in this community. And so that is what I object to, is the fact that we are still here trying to, which sounds like it could be a relatively easy fix, but it's not. What happened as a fix was we kicked out the black and brown and poverty populations that were living in this neighborhood because this was a place that they could afford to come and buy. It was a redlined area, and if we look at the historical issues, socioeconomic issues that addressed why this neighborhood was created the way it was created, for the benefit of the haves, it was the have-nots that got screwed. And so I just wanted to say that I thank Central Health for being a part of that conversation, but we also need to remind the city that this is something that they created, and they need to step up to taking care of it.
Thank you.
I'd like to say one thing, Manager Valadez. I completely understand how much you care for the poor and the homeless, and I really appreciate your statement. Thank you.
So members, if there are no other comments or questions, I'm going to move us to item number 4, which is to receive, and thank you, Dr. Lee and Ted, for the update on the East Cesar Chavez neighborhood concerns. Item 4 is receive an update on Central Health's Communications Awareness Survey results, and Ted Burton will be presenting with Daniela Lopez and Derek Stafford from Census.
Thank you, Chair. Appreciate that. We are moving on to talk about our most recent brand awareness survey, and I'm happy to be here with our partners from Census. And Census is our advertising and research partner. They've been with us for about a year. Real quickly, we're going to talk about the latest survey. And historically, this has been a biannual survey, but we are going to move and start doing these annually. The reason this survey is important is that this sharpens our messages for the different audiences that we speak with. It's how we prioritize our marketing and communication efforts by channel, and how we measure the impact of our work. I believe this is an obligation to taxpayers to demonstrate the value of the work that we're doing, and I think today you're going to hear some very exciting news and information, and also some really important areas for opportunities for growth. With that, I'll let Daniela introduce her team, and then we'll dive right in.
Well, thank you for the introduction, Ted. And yes, my name is Daniela Lopez. I am the lead and representative here for Census. A little bit about Census. Ted just mentioned some points, but we have been in Austin for almost 15 years. We are a multicultural and full-service agency, helping and supporting Central Health communicate and engage with the community that they serve. We have also worked with Cap Metro, City of Austin, and also UT Health. Also developed advertising campaigns to engage, inform, and also drive actions, all rooted in research. Now, I'm going to introduce our research director, Derek Stafford. He is a published researcher with a PhD in survey and methodology, and he will walk us through some of the findings that we executed for the survey.
And Derek is online, so he'll be joining us virtually, but we can go to the next slide. And will we see Derek during the presentation? I can't see if he's...
Can you see me now?
We can hear you for sure.
Okay.
Hopefully we can also see you on the screen. So let me just, oh good, great, fantastic. So this effort supports our FY26 objective to demonstrate the value of community support here in Travis County. And I'll start with the big headline. Derek, I'm sorry, I'm going to steal a little bit of your thunder, but you're going to come back and make me sound a lot smarter. But Central Health is the market leader among current patients, and Derek's going to show you the data behind that. But this is really important. When you talk to people who've used our services, whether they're Sendero members, community care patients, or Central Health patients, they choose us above all other healthcare systems in the market. The research will show you that we've increased awareness among all demographics across Travis County, but strongest most among Spanish-speaking households, Latinos, and African Americans. 84% believe that Central Health provides value to the community. This is another really important slide for us because, as you can see, it's one of the objectives that we're measuring ourselves against. There's still nearly universal support for our mission here in Central Health. As Derek might remind us, we tweaked down slightly from the last survey, but it's really hard to go down from almost perfect, and he'll explain that data point as well. And here's a really important one. I think this goes to everybody in this room and throughout the system. Central Health awareness has increased for Central Health by 21% over the last 6 years, 15% for community care. MAP is up 21%, and Sendero is up 9%. So now we'll dive into some of that data. And I think one of the bottom lines for me is it shows that this comprehensive strategic approach to communication and marketing is working. So I'd like to thank you as a board for investing in this and believing in this because it's paying off. And now I'll introduce Derek and let him take over from here. Derek?
Thank you, Ted. Thank you, Ted. Thank you, Daniela. And thank you, everyone else, for your time. I wanted to spend a minute talking about research methodology. Perhaps we'll talk about this a little bit more than most people would normally expect. But Ted made it clear to me that the board really, the methodology is really important, and having a representative sample is really important to the board as well. So our primary goal for research methodology was to provide Central Health with as representative a sample of Travis County as possible. It is impossible to perfectly represent any population with a sample. Even the census doesn't capture everyone. And
Derek, do you mind moving closer to your microphone so that we can hear you clearly?
Sure.
And then maybe slow down just a little bit. It's a little bit more challenging when you're virtual. Thank you very much.
Can you hear me now?
Even lean in closer if you don't mind.
Is this better?
Can you hear okay, board? Okay. And then slow down. I know you're excited and so am I, but yeah, we want them to absorb.
Will do. Our primary goal for research methodology was to provide Central Health with as representative a sample as possible of Travis County as possible. It is impossible to perfectly represent any population with the samples. Even the census doesn't perfectly capture everyone, and it underrepresents certain groups. However, we put great effort into providing Central Health with as representative a sample as possible for as reasonable a price as we could. We conducted the survey with 928 Travis County residents. The survey had about 65 questions, and the average completion time was about 30 minutes. We developed a sampling method that involved gathering 700 surveys through online panels, then doing analysis twice per week on the demographic and geographic distribution of the sample, comparing it to the most recent census data, then using that analysis to guide surveyors to augment the online panel with in-person surveys that could address any demographic or geographic incongruities between the online panel and the census data. To state that a little bit more simply, while gathering the data over a month, twice a week, we analyzed the data to make sure that every ethnicity, zip code, and other demographic variable matched the census data. When one category or zip code seemed underrepresented, census in-field staff would recruit people in public places in Travis County that match those descriptions and those geographic areas. So we go to those specific zip codes. We also worked to include oversampling quotas for certain key demographics, like Spanish-speaking households. The study was then weighted by the census data prior to any analysis. Basically, this means that, and this is standard in any scientific survey, if, let's say, hypothetically, 40% of the sample was female and 60% was male, but the true percentage in Travis County is 50%, then we weight the sample so that when we do analysis, the female sample carries more weight and is worth 50% of the sample. We did this across several demographic variables to make sure that the analysis truly represents Travis County. Again, this is standard practice in scientific research. All of these complex processes were designed to ensure representativeness. I'd also like to take a moment to focus on one important aspect of the study, language translations. The survey was only translated into English and Spanish because to translate the survey properly across dozens of possible languages would have cost more than the study itself. We also would have needed field staff that spoke all of those languages. We researched the languages spoken in Austin by individuals unable to speak English or Spanish, and those groups represented very small fractions of the population that would be unlikely to affect the overall analysis. To clarify, I'm not talking about the percentage of people in Travis County who speak different languages, but rather the percentage of people who cannot communicate in English or Spanish, because anyone who speaks either of those languages could complete the survey, even if they also speak other languages. Even so, to make sure that our assumptions were correct, we added a screener so that we could record how many people couldn't take the survey because of a language difference. In real time, we could assess the magnitude of the problem and commission additional translations if it was required. Out of a total of 932 total people recruited, only 4 people could not proceed with the survey in English or Spanish. This represents 0.4% of the sample and mathematically could not affect the significance of the other metrics or analysis you'll see today. Next.
Next slide.
So some key findings and takeaways. Some key takeaways from the report would be that Central Health leads all competitors in favorability among current patients. However, favorability amongst non-patients lags competitor brands. Reputation among those who don't use our services is weaker than among current patients. In other words, we deliver well for our patients and the people we serve, but we're not fully understood by others in Travis County. This is an opportunity for growth. Next. A few more key findings. Other top-level findings are that awareness is increasing across all demographics, and the strongest gains are being made with Spanish-speaking households, Latinos, and African Americans. We also continue to see broad support for Central Health's mission across all communities in Travis County. And as I discussed on the previous slide, Our highest favorability ratings are from current patients, meaning when people experience you, they give you really high marks. Next.
And I'd just like to say, we could applaud the people that work in our clinics, from the folks that greet patients when they walk in, to our providers, to the folks that are working the eligibility phones, meeting with people in person, outreach staff. I think it's a reflection on anybody who interacts with anyone with the Central Health System walks away feeling really good about that. And so I feel like it's a chance to give a shout out to our colleagues that aren't here, that are either working or hopefully resting up for another day's work tomorrow, because it's really where the rubber meets the road. It's our patients telling us that they choose us over other healthcare systems here in Travis County. So just wanted to emphasize that.
Absolutely. So this is about.
Sorry, Manager Jefferson, you have a
Derek,
question?
1 sec.
So when you asked the question about favorability over competitors, is the population basically those who are Medicaid? Because is MAP available through any of the other systems that are mentioned here later?
Will you explain the actual question, Derek, that is asked? And
Sure.
she's asking about basically who we polled and how they were polled.
Yeah, so all of the people, so we try to get a representative sample of Travis County, which would include people on Medicaid, not Medicaid. It would include all sort of backgrounds of individuals. Then those individuals, each of those individuals were asked about, and I'll get into this more on the next slide, after this slide. They were then asked about whether they were current patients of Central Health. They were asked about awareness of Central Health. If they were aware of Central Health, we then asked had they ever visited Central Health, or they've been in clinic. I forget the specific questions, but they were more in depth about how recently they had been to Central Health, and or if they knew of MAP, if they were aware of Sendero. We asked
Community care,
across.
right.
Right. And then those questions, and then from those individuals, we also ask questions about their perception of the favorability of Central Health. We also asked non-patients who were aware of Central Health about their favorability for comparison purposes. Obviously, we can't ask people who said they were not aware of Central Health about their favorability, because they're not aware of Central Health. So each of those different groups got that question on favorability.
Go ahead.
And we'll go into that more on the next slide, but just to finish up with this one is about percent of the people who support healthcare as a human right. And as you'll see, it remains incredibly high. The Austin community nearly universally supports Central Health's mission to ensure all residents have access to health services. Remember, this is scaled here. So like the lowest percentage that you see there is like 70, it looks like 76%. So to the naked eye, it appears as though there's a slight decline, and there is a slight decline, but it's very slight. And really, we are seeing small differences, which could be due to macroeconomic and political conditions. Quite frankly, how people feel about the country and the world affect how they answer questions like this. And it's hard to go up from 90%. So if you notice, the original stats from 2019 originated at 90%. Next. Here's
Can I ask a question?
Sure.
So I think I'm hearing what you're saying, but basically going from 94% down to like 80 in the 80s.
Yeah.
So are you saying that's not significant? Is that what you're saying? Because everyone should have access to healthcare is important for us in the
And
community.
we asked it in two different ways, because we tested two different questions. Derek, you can be blunt like you were with me when I asked the same question that Manager Kitchen is asking.
Something very important happened between when the survey was asked in 2024 and 2025, and that was the presidential election. My guess would be, if you want to look at cause and what's driving changes in those sentiments, I would have a lot to be about the existing political climate and how people feel about it.
Okay, thank you. I think that's important for us to understand.
And again, when you look at from 2019, so over the duration of when these numbers have been tracked, it's gone from 90% to 88% in one column, and from 90% to 85% in another. So those are relatively stable numbers over time. We don't see huge dips of 20%.
And the two different lines indicate the two different ways we asked the question. So one was everyone should have access to healthcare no matter how much they earn, where they live, or where they're from. And then the blue bar, it's healthcare is a basic human right. I don't think we asked, yeah, we did, never mind. But so we asked the question two different ways to see which one might resonate more powerfully.
And Derek, I might just add that it's probably worth it, and defer to you on researching it, but the other factor in addition to the elections might be that the in-migration to Austin has changed from California and other outside states to in-migration, the majority is in-migration from other parts of Texas. So that could also have an impact on those numbers as well.
I think that's a very valid hypothesis, and that's one of the reasons why it's difficult to correlate time series data over periods of time where you have a number of different explanatory variables that could cause those things. But that seems like a very valid hypothesis to me as well.
Derek, I'm curious, are you aware of how this compares to other communities? So how might this compare to other communities in Texas or around the country? How high of a support for health as a human right is this, relatively speaking?
That's a phenomenal question that unfortunately I don't have an answer for. This survey was obviously limited to Travis County, but I'd be interested in exploring those numbers myself. And I don't know if we could get the exact question in that way in other communities as well, but there may be similar questions in publicly available data sets that I could look at.
Thank you.
I'm sorry. I just have one quick, easy question. I think you can answer very quickly. What was the number of respondents that were non-English speakers?
I don't have that right on hand. It's on another slide, but it was certainly over 100. I believe it was over 200.
Okay, whenever I can find that.
We can get it to you.
Yeah, thank you. And a copy of the questions asked.
And Chair and Derek, while we're just piling comments onto this slide, I want to point out that to me, if we were to walk away and take this as a given, there are two lessons. There's a potential lesson in opinion, and there's a potential lesson in messaging. And I think that's pretty critical, especially in the work that we may have to do in the years ahead. And so I think that was maybe what Manager Kitchen was kind of heading toward.
Certainly, and one other thing though to take note here, and I don't mean to go too far off into the weeds here with statistics and stuff, but if we were to take the confidence intervals between that first number from 2019 and the numbers from 2025, I'm almost 100% sure that the confidence intervals would overlap, meaning that we can't even be 95% sure that those numbers are actually statistically different from one another. And so I see, when I look at this graph, I know the numbers, you see the lines move around, but I see a rather stable support for healthcare as a human right. And the fact that both lines move similarly too, I think that's an indication of the robustness of that field.
Go ahead. Next slide.
So this was some of the numbers from favorability we talked about earlier. This is one of the more impactful findings from our research. Here we're looking at favorability ratings for Central Health and its competitors. The darker blue represents current patients and the lighter blue represents non-patients. So you notice that Central Health leads all of its competitors in terms of favorability by its own patients. But it also has the largest difference between its favorability amongst patients and non-patients. The takeaway is clear. Central Health is performing at a high level for its patients, but for non-patients, they don't necessarily view Central Health in that way. This is an opportunity for growth. Marketing can work to bridge the gap between performance and perception. It's also worth noting that the MAP program and community care score really highly in favorability as well. Sendero may be lower than some of the other brands, but it isn't necessarily a fair comparison for Sendero, given that Sendero's the only nonprofit health insurance company on this list. It's also the only insurance company of any kind on this graph. It's a bit like comparing apples to oranges.
And we included MAP because we just, MAP's a program, we all know that, but we did want to see, we wanted to measure the awareness and favorability of MAP as well. So that's why we included MAP along with healthcare systems and with Sendero.
Just real quickly, before we leave this slide, unless you have a better slide somewhere, within those that had no understanding or knowledge of Central Health and that were non-users of our services, and I guess the non-insured population in Travis County, because we know what that finite number could be. How do you discern whether it has anything to do with their actual knowledge? Did you ask the question? How are you able to discern?
I'm sorry. I'm just trying to understand.
I'm trying to understand when you ask the question of the non-patient users.
Mm-hmm.
You asked them, do you even know what Central Health is?
Yes. So
Okay, and then for the people that are not insured, not part of our program, not appearing anywhere in our records, and that amount of people, 150,000 plus in Travis County, how did you get to those, or you didn't?
So
You just
the
didn't.
answer is, well, no. So the answer is that the 928 people all got the question. Are you aware of Central Health, or are you aware of the MAP program? Are you aware of them? They each got those separate questions, right?
Yes.
For people who were aware, they then got for people who weren't aware, they then got other questions later on. Right. For people who say they are aware of Central Health, we then ask them follow-up questions about their use of Central Health. If they say they haven't
I got it.
used
I
Central
understand.
Health, so they then
It'll come up in the,
Yep.
in another.
right.
And I know
And
we're
so-
saying Central Health, but there were times that we were asking about Central Health and times we're asking about Central Health, Community Care, Sendero. So at times it's the system, and we're going to address that question later. I think it's actually a positive and surprising finding for me. But just want to make sure, Derek, I know a lot of times you're just saying Central Health, but we were asking specific questions about the different entities, et cetera.
Yeah, each of these represent different ones. I was using Central Health as an example,
Yep.
right? So they're asked about their awareness of Central Health. They're asked about their awareness, Sendero, about community care, about each of those things separately. And then based on how those answer those questions, they get follow-up about usage. So what you're seeing here is among non-patients, you're getting people who say they are aware of, again, for one example, but each of the institutions get this. They were asked that they were told that they responded they are aware of Central Health, but then they responded they didn't use Central Health in any way. And so those are the people who are non-patients, but they are aware of Central Health, so they can give an idea of their opinion of favorability, right? Whereas people who aren't aware of Central Health, we can't ask them about their level of favorability of Central Health because they're not aware of it. Does it make sense?
Yeah, thank you so much. We'll keep moving because I want to respect everybody's time. Thank you, Derek. Next slide.
Yes. Speaking of which, here's awareness. So over the past 6 years, Central Health has been tracking awareness of system brands in Travis County. The different colors represent different years of the brand tracker since 2019. The growth has been significant and steady year over year, with the exception of Sendero Health. Sendero Health, you see a bit of a decline before it popped up this past year. But with the largest jump occurring in almost all of these from 2024 to 2025. Although all Central Health Systems brands have grown since we began tracking, the largest increases have been for MAP and Central Health at 21% apiece.
And this is the first time that we had added Carousel Pediatrics to the survey.
I have a question about that. Is Carousel Pediatrics still a name being used? Because I know you're trying to find what
It is.
the people who are being surveyed knew. So it is still being used actively? Okay.
Next slide, if we've already. So top of mind awareness refers to the unaided recall of a person when prompted about a specific concept. So, for instance, in this case, the respondents were asked to recall local healthcare systems. Central Health scored lower than these top brands in unaided recall. But Central Health is continuing to gain ground. 35% may sound low in comparison to the other top brands, but just a few years ago, that number would have only been 14%. So again, a significant increase over time. Next. All right, this is a bit, sorry for how complicated this one looks. I'll try to walk you through it. Here we see awareness of Central Health System brands by Spanish versus English-speaking households. Spanish-speaking households are in pink, while English-speaking households are in blue. Each row shows the awareness of these groups for a specific brand in the Central Health System. For instance, across the top row, awareness of Central Health in Spanish-speaking households climbs from 12% in 2019 to 37% in 2025. The following numbers all refer to Spanish-speaking households. Community care climbs from 32% in 2019 to 61% in 2025. Sendero Health fluctuates, but also climbs from 20% to 31%. And MAP program has shown the most growth, going from 26% to 63%. Carousel Pediatrics, we have only been tracking this year, and awareness measures 56%. The trends are consistent with the previous slides, and that Central Health System brands are growing steadily, and that growth occurs within English-speaking homes as well. The growth is most dramatic, however, with Spanish-speaking homes.
Next slide.
Next. This graph is similar to the previous one, with the key differences being that the colors now represent different ethnicities. Again, we see growth across all brands and all ethnic groups, but the growth is steeper with Latinos and African Americans. I'd like to draw your attention to a few of the largest differences. Amongst African Americans, Central Health awareness has risen from 9% in 2019 to 40% in 2025. Again, for African Americans, community care has climbed from 31% to 73%. MAP has grown really significantly amongst both Latinos and African Americans, going from 32% to 60% and from 22 to 62% respectively. With Sendero, we also see significant gains with both African Americans and Latinos. Next. In terms of brand perception, 57% of Travis County respondents say that Central Health is very valuable to the community, and 84% indicate that Central Health is either very or somewhat valuable to the community. I know providing value to Travis County is a priority for Central Health, and having 84% of the population already feel that Central Health provides value to the community is an excellent start. Next. Now we look at how people perceive of Central Health's value by income. Both high and low income Travis County residents perceive of Central Health as valuable, but the percentages are slightly higher for lower income people than it is for higher income people. Next. So this is Central Health performance by category, and we're emphasizing Spanish versus English speakers here again, where you can again see that the Spanish speaking households are in pink and the English speaking households are in blue. The categories are helping people get healthcare, delivering high quality care for low income and uninsured residents, improving early diagnosis and prevention, bringing more care to people with new clinics, more doctors, and better care. While Central Health scores well on average, the scores are consistently higher again for Spanish-speaking residents than English-speaking residents. Central Health has the largest differences between English and Spanish-speaking houses for helping people get access to healthcare. That's the biggest difference there, that first one. Next. Here we see the same four categories of performance, but this time the colors represent whether the resident is above or below 200% of the federal poverty line. Again, we see Central Health score well among both groups, but highest amongst poor individuals in Travis County. In terms of categories, the largest difference between those making 200% above or below the poverty line is the category bringing more care to more people with new clinics, more doctors, and better care. with people below 200% of the poverty line giving Central Health higher marks. Next. I think this is a slide that Ted had something he wanted to say on as well.
So this is really the first year and a half that we've actually been talking about the Central Health system publicly and trying to educate the community on the fact that we are a unified healthcare system. I was surprised by this number, and Derek might have tamped down my excitement just a little bit, but without putting a lot of effort and a lot of time behind talking about Central Health as a system, you can see that 74% of those that were polled were aware that there was a connectedness, that we were part of a system. And Derek, you had some context to that. People might want to answer the question that way when they're asked, but go ahead and kill my joy.
So, given the new emphasis on making sure the public understands that community care and Sendero Health plans are affiliated with Central Health, we want to begin to measure that metric here. Although 70% knowledge of that system connectedness may seem high, I just want to add two caveats. The first is this question was only asked to people who are already aware of Central Health, so it isn't of the entire population, because of course, how could we ask them if they knew these systems are connected if they are not aware of these systems in the first place? And two, anytime you ask a knowledge-based question in this way, you are likely to get more than 50% of the population saying yes, simply because cognitively people prefer to say yes, they're aware than no, they're unaware. In subsequent waves of this study, we will make sure to include additional questions that allow us to tamp down on the results a little bit further and dig deeper to make sure that we get you accurate results.
And we have just 3 more slides as a time check, Chair. Thank you. Go ahead, Derek.
Yeah, I can move quicker if you'd like. Net Promoter Score is a widely used survey method that measures customer loyalty and overall sentiment toward an organization, product, or service. It is typically based on a single question asking respondents how likely they are to recommend something to others on a scale of 0 to 10. Respondents who are grouped into 3 categories: promoters, who score 9 to 10, and they're enthusiastic and likely to drive a positive word of mouth; passive promoters, who are satisfied but not strongly loyal; and detractors, 0 to 6, who may discourage others from engaging. Here, 51% of Central Health patients are strong promoters of Central Health, and 27% are weak promoters, but promoters nonetheless. This means that nearly 80% of Central Health patients are promoters. This is excellent and another indication of high quality of performance. Next. Again, we see the same net promoter metrics from the previous slide, but this time we separated out English and Spanish-speaking patients. Similar to what we saw in other metrics, Spanish-speaking patients are exceptionally strong promoters of Central Health.
May I ask one quick question? Did you take into account whether or not people are driving here or taking a bus here?
I don't believe that was the question that was asked.
Okay, I think that's an interesting question to ask.
I think you're right, and that's something to explore in the future.
Okay.
And that could be something that we touch on in qualitative research, focus groups, interviews, etc.
Absolutely.
I think we're at the final slide. Go ahead.
So, from 2025, Central Health has dramatically improved its awareness across nearly all demographics. Awareness is highest among Latin Americans, African Americans, Spanish speakers, and poorer households. Favorability fluctuates, but amongst patients, we also see increases amongst non-patients. Favorability is low, indicating a gap between performance and perception. As expected, support for the Central Health mission is lower amongst voters and people with higher income than non-voters and people with lower income. Central Health has clearly targeted key audiences for marketing and messaging. Central Health has been successful with those efforts, which has created a gap in awareness, favorability, and values between target audiences and non-target audiences, in particular the non-target audience, white, male, and high income and voters. If changing perceptions with those groups are important, Central Health should treat those groups as strategic targets as well and create distinct messaging, concepts, and targeting strategies for audiences to impact their perception of Central Health. Just two final items. One, I know Ted is already working on those things and excited to be working with him on it. And one other final note, it's been fantastic working with Central Health on this project because to have a client who cares so much about research methodology and making sure we get the best numbers to you possible and did not care at all about the results, but the process, it's been a real joy to work with your team.
That's Derek's nice way of saying, tell Ted to quit emailing me and texting me and calling me, right, Derek?
No, he says, give me
not
another
nearly as well.
contract.
Thank you.
Thanks. Thank you, Derek. Very thorough. That's it. And I'll just say now comes the action. We turn the data into action. I've been here for 10 years. We've never really focused on audiences beyond our patient population, connecting people to care and coverage. This year, we're making a concerted and strategic effort to talk to the broader audience, all taxpayers of Travis County. We have a campaign that's under development, and we'll be bringing that back to you when it's ready to go. So I've heard before from some of you and others, people just don't know about Central Health. Well, this shows that we're making improvements, but we do have work to do. And so we'll bring back that campaign to you at a later date to show you where we're headed.
Thank you. Managers, any last questions before we move to the next item?
I have one quick.
Yes, 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 sir.
Thank you. It was really great work. Thank you. And Ted, I think it's wonderful that the future is connecting to the non-patients who are paying the taxes. They understand what we're doing. They need to know that. So thank you.
Thank you.
Just a quick question, and I think maybe you've answered it, but on your strategic recommendations, the last one about creating distinct messaging impacting the perceptions of those groups, would that encompass the getting at the result that we saw about I think it was called the top of mind, that we're like 35% top of mind?
Absolutely.
So this strategy is also designed to raise that?
Absolutely.
Okay.
We've never traditionally done what we would call a brand awareness campaign. We've been very focused on our patient population, and we're expanding the scope and the reach. So hopefully we'll see that number increase next year.
Members, yes, yes.
Okay, Ted, I still am always interested in what is the issue with getting the non-users or non-familiar with Central Health people into our house, okay? And I don't think we've gotten a good handle on that. So maybe he might have an idea as to what we should do and include that in some kind of just a conversation.
The
Just a
simple answer is
conversation.
awareness. They have
I
to know
know.
about us, right? So that's one of our focuses, and we don't do that just with an ad campaign.
No, that's right.
It's a comprehensive campaign. It's the people that are out on the streets, our outreach teams. It's our engagement strategies.
7 touches.
Yep. So I think that's the simple answer, but Derek may have more to add, or Danny,
Thank
you
you.
may have more to add.
And how people get to our clinics is an important
Yeah,
issue.
transportation.
Yeah, I think the transportation piece, as was suggested earlier, is a great idea. I also think that reaching out and targeting people more directly who show lower awareness
Right.
and making sure that it's sort of inclusive of all of those individuals as well would be helpful. And I know those are things Ted's already working on. And the other thing I would note is, we do a lot of these brand trackers for a lot of different companies, and the growth that you're seeing over the past 6 years is quite large. Like it's not just significant; it's like the magnitude of it is large as well. And so I know there's always more work to be done. I understand it's the job of this board to push those limits and to push to make even more progress. But I also think there's reasons to believe that success is already occurring too.
And then remember, I just had 2 really quick comments. Not you don't need to answer them now. I think one from a governance perspective, like insight and foresight. One, I really appreciate the long explanation about the methodology, because I think that's really important for us to understand and trust that methodology. And if we don't, to ask questions. I think the second one is really for some other time. I'm just curious about the translational data and how it's used to add value to the rest of the organization. And I'm sure you take some of this work and use it to benefit and increase kind of, I don't want to call it market share, but the patients in increasing their trust and coming into us. But I'd be curious to see in the future, like examples of that, in addition to the takeaways and recommendations, but what the outcome or impact is of the translational nature of the data that you're using, and what kind of an impact or outcome it's having to the organization. And with that, I want to thank you all for being here and online as well. And we're going to move on to item 5, so that members can go home before midnight. Item number 5 is receive and discuss an update on the process and calendar for developing objectives and key results, key performance indicators, and the budget for fiscal year 2027. Dr. Lee, Jeff Knodel, Kim Heinonen, and Anissa Kendall will be presenting. And I think members, out of respect for time, I know Dr. Lee's agreed to kind of shorten the presentation so we can move to the next item. So Dr. Lee, thank you.
Thank you, Chair Rodriguez. Thank you, managers. I just want to share how excited I am for this year. This is the third round of going through the budget cycle together. Each year we keep getting better. This year, I think we're getting close to best practice, and I'm going to just briefly walk through what I think that best practice could look like. We look forward to your feedback. This is our official kickoff. This year, we are proposing that there are 5 key approvals that the board will move forward at each stage of this process in sequence, moving us up to the final approval, of course, which is the budget itself. So what are those key approvals? The first actually is a core set of board policies that will set the whole stage for the budget annual planning process. These include contracts with community-based organizations, an annual planning policy, an annual budget policy, a financial reserves funds policy, and a contract management policy. So we're in the process of getting early drafts of these. We will, of course, bring them to the board, share them in advance, and look forward to robust discussion. The goal is to see if we can't get these approved during the March board meeting, if we can, as really a foundation to everything that comes afterward, and then hopefully we'll be following those policies through the year. The second base, then, the second kind of approval step, is a critical step that we have called driving forces. The board member members, we did this, I think this will be our 3rd year. Driving forces is also, you can think of this as a SWOT, strengths, weaknesses, opportunities, and threats of our sort of annual planning process. So there's things that we anticipated in our strategic plans, in our transformation resolution, and so on. But each year, the world changes around us, and this is a way to really try and capture that, really have the board discern, and then this is our SWOT heading into this fiscal year planning. So we'll bring a draft, but again, this will be a hopefully rich discussion. This is teed up for March. Third in this stop then is the system objectives and key results for the next fiscal year. These OKRs are informed by everything else before that. The driving forces, the system transformation resolution, the healthcare equity plan, our current progress in the year of access, and so on. We pull it together. Less is more. The goal is to see if we can get maybe to 3, no more than 8, key results that we want to drive toward across the system. Of course, these are top level, and they'll iterate through the entire organization. And these will be board approved. Our target is April. And OKRs, importantly, as you will hear, this is what we want to improve. So we're going to say performance is here, but we want performance to be here. And we're going to raise the standard and focus our efforts to try to drive that part of the system forward. The 4th stop in the journey is what are called key performance indicators. As you'll hear, KPIs are different than OKRs, and that key performance indicators are saying what is the vital performance you want to maintain. Don't take your eye off these balls, because these have to remain at this benchmark level while we try to elevate the game with these OKRs. So the board will also review and approve the KPIs and the targets. Again, less is more. And so that's fourth step there. In parallel to all of these 4 stages, we'll be having our annual community conversations starting in March and carrying through July, through all 4 precincts, and then with the judge in July. Those conversations will be in dialogue with our process and informing the process. And then after we have the driving forces, the OKRs and the KPIs all board directed, that then sets the frame for the budget. We will then develop, staff will work diligently to develop a set of activities, a how, if you will, to meet those ambitious objectives set by the board and cost those out and stay within the boundaries of the budget limitations and bring these back likely in iterative cycles, building to a tax rate and a budget. That will be the 5th and final step in the process, a board approval, ideally in August, latest early September, followed by the court's approval finally in September. So this is sort of a 5-part sequence that we are going to go through this year, and then hopefully can actually repeat in this sequence in future years. If it goes well, we'll always adjust and follow board direction. But this is getting closer to best practice. I'm really excited that we're ready to do this in sequence this year. And with that, hand over our team to walk through the detailed timeline. The last thing I'll mention is we want to strive to present this clearly in a way that makes sense to board members. So please give us feedback on how we're doing with that. And if there's a way that we can do it better, we're more than happy to make those adjustments as we go. And again, just really excited that we're at the launching point here. Thank you.
Chair, in the interest of time, I could ask a question now, or instead of them going through all of this, if you want. Okay, yes.
So that they answer it while they're presenting?
Yeah, if you want to do that. So the policies you mentioned, I'm not seeing them in writing, so please go over them again because I didn't catch them. And then the second thing, as you go through this, I'm not seeing where on the timeline we talk about the board input on, I forget how we've talked about them in years past, but we've had in our timeline, we've had the opportunity for board submittal of whatever we call those things, initiatives. And I don't see that on the timeline, so talk about that too.
Sure. So the 5 policies, Manager Kitchen, we could name them differently. These are the content of the policies.
Well, I don't care what they're named, I just couldn't catch it.
So the first is contracts with community-based organizations.
Okay.
The second is the annual planning policy, sort of describing the sequencing we're just talking about here. Third is the annual budget policy. The 4th is the financial reserve funds policy. Mm-hmm. And the 5th is the contract management policy.
And I would just add that I think what we're trying to encourage, Dr. Lee, is to make sure that we have more time, as much time as possible, to ensure that we're giving feedback through our committee process, whether it's executive committee to board of managers or whatever that process is, to make sure that these foundational policies can be informing the budget process. And I think the other question I think you had was around the budget initiative process. I think the other thing I would encourage you is if these 5 policies are not the only ones that you all think should be, then please give input about what policies should be in place. I think that's why we're early sharing that. And then around the budget initiatives, from my perspective, there's no deadline to that. I think if you have ideas about what that should be, we should be giving them now to Dr. Lee and his team so that they can discern them, because those initiatives should be part of the budget process and not like towards the end of the process. Mm-hmm. So I think to that extent, we want to make sure that we're getting the input from the board sooner than later to inform the development of this process. So at the end of the day, when we vote, obviously we own that budget at the end of the day, and so it's important for us to give as much input, insight, foresight about what it is that we're trying to accomplish with the budget.
So Chair, that's very different than we've done it for the last 2 years, which is fine. Yeah. I'm not suggesting we need to do it the same. It's just we need to make sure the board understands what we're doing this year. Because in previous years, we've had like a process, a timeline, a form we had to submit, all that kind of stuff. Yeah. And so whatever we're doing, we need to make it clear for folks.
Yeah, and I think part of the presentation is an entire timeline that where because in talking to Dr. Lee and Elisa and I thought, was to highlight where the board role is and the board opportunities are. And so I think you'll see it
It's not on
in
here.
the,
It's not on here.
it's, or maybe it's coming in the future, but I'll let them kind of go through their
Okay.
presentation, so that we can get to the other items. that
Or
we
maybe
have.
it's inherent in this, but just,
Yeah.
it needs to be words in
Yeah.
here that we can see it.
Yeah.
Yeah, okay.
What was that last thing, Dr. Lee? Year 5? I had the 4, I missed the last one. Slow rider.
Number 5 is contract management policy.
Well,
Contract
because I
management.
have contracts and policies and budget, and it's like, everything is
So-
contracts, and.
The first is how we work with community-based organizations.
As far as I'm concerned, in my head, the way I look at things, contracts, and it's either contracts with outside partners, with community-based organizations, whatever. That's all has to do with contracts, okay? Then something else is going to be, it could be governance or budget, governance, and then the third one is budget. So they're all in. Everything having to do with contracts is in one bucket. Everything having to do with budget is in one bucket. Everything having to do with something else is in one bucket. But I don't believe we've had that discussion as a board. And so when, I'm wondering if that's one of the reasons things keep changing. We're told at the beginning of the budget process, this is the way we're gonna do it. And it's been told to us either by you or by Jeannie. And so I prefer the kind of person that has a discussion about we as a board, what do we want to do?
Yeah.
Okay,
Yeah.
and this is what we would like to see. And then, somebody tells me, okay, well, this is what we're gonna go ahead and do. As
Manager Valls,
opposed to-
that is the intent, is this year for the board to tell us what the process will be. So what we're gonna do is provide an initial, very rough draft. We've bucketed it in 5 buckets. If we would make it 4 or 3 buckets or 6 or 7 buckets, this is at the board's prerogative. Our hope is that there will be clarity,
Yes.
a vote, right? Maybe on all policies or policy by policy, and then we will follow the policies, and everybody will know. And we're going to follow the board direction this year and do that up front. That's the intent.
I appreciate that. It just makes me a little nervous when we're supposed to be looking at working on voting for implementing the, let's say, governance policies or this policies or that policies, but we're going to be doing these other policies also. And then it becomes almost like a haphazard. Maybe it's not, but it just feels as if it's not organized. And
I hear you.
and that's the only reason I'm asking for clarification.
Thank you. And actually, I should say that our recommendation is that we prioritize the policies that are informing our budget process, because that's sort of now, and maybe if it's acceptable to the board, we kind of take these first so that we have clarity. And there's some that we may be able to do after, but we want this right up front, to your point, Manager Valdez, so that we are following the board's direction on the budget process.
And we'll have more on the process when we end up discussing another item in executive session around the governance consultant as well.
I appreciate that,
Yeah.
because then what I would be doing is, as soon as we have our fiscal budget approved in September, then October, we're gonna work on what our priorities are gonna be, not here in the middle, right before budget, okay? So I think we're losing 5 months, is what I'm saying. I guess that's just my way of thinking.
Dr. Martin, before we
30
get
seconds,
the-
I
yeah.
swear. To me, the whole idea of board initiatives is not a power we've really been approved for. I mean, who are we but managers? And these, to me, over the past years have come across just as pet projects of individuals and not the board. I'm all for the board proposing initiatives as a board, but as individuals, it seems misplaced.
Well, can I speak to that for a second?
Sure.
I agree that we don't want to be doing like pet projects. When I say board initiatives, that's not what I mean. What I mean is, if we want to propose as an individual board member for the rest of the board to discuss an idea that relates to an overall approach for this particular budget, then I just want to know when in these meetings we do that. That's all I'm talking about.
I It's just has been a slippery slope to individual things. Because it's all mission driven, but it becomes one thing over another. And I think my experience has been the past several years that we tend to lose perspective. I totally agree with you about the presentation, the idea. So thank you.
Okay, well then, I just wish not to identify
Yeah.
where in here we're doing
Yeah,
that.
and I think the sequence is the sooner the better so that we can all as a board discern it. But yes, we'll get some clarity on it.
Okay, yeah, I just need,
Yeah.
sooner the better is what board meeting and who do I send it to?
Got it,
That's the
yeah.
question I want
Got
to
it.
know.
Thank you.
again?
Yes.
Thank you, Dr. Lee. Board Chair, Vice Chair, and managers, thank you for your time today. My name is Anissa Kendall, and I'm the Senior Director of Strategic Planning. And I'm joined by Jeff Knodel, Chief Financial Officer, and Kim Heinen, our Chief Transformation Officer. And we're excited to kick off the development of the FY27 annual budget. Our presentation today will hopefully provide an overview of the process, which includes establishing OKRs, the budget timeline, and ongoing board engagement throughout each phase. Next slide, please. So Central Health is transforming, and our transformation to the system reflects intentional work, guided by the board's direction to strengthen how we plan, invest, and measure impact. This slide reflects that journey and how we continue to moving forward with purpose, starting with what we are trying to accomplish. We are committed to building a seamless, high-quality, equitable, affordable, ambulatory continuum of care. And doing this work as an integrated system with community care and Sendero, with shared and measurable goals. And as Dr. Lee mentioned, each budget year continues to keep getting better as we continue to mature our processes through a more structured approach that includes more disciplined planning of resources, financial investments, and tracking. And essential to this process and the transformation work is the board's leadership by defining and approving the annual planning process, starting with the board-adopted system transformation resolution, strategic plan, the board policies, driving forces, and system-wide measures. The staff then will execute the board's direction by developing the annual budget, performance measures to track progress, community value, and fiscal stewardship. Next slide, please. This is a slide the board has seen before. It's intended to provide a visual overview of the current annual budget process, which includes the key components, how they build on one another, and how the board remains continuously engaged. As I mentioned earlier, this year's process will now begin with the System Transformation Resolution, which was adopted in January and sets a clear direction for Central Health. Moving to the top box, nested under the resolution, are the plans and policies that we just discussed. Then the flow into that green box, setting the system OKRs, KPIs, again with the board's guidance. Continue moving clockwise to the orange box, the staff develops the strategic budget initiatives, the planned work, that aligns to the system objectives and goals, again approved by the board. Then moving to the green box, the staff then prepares the budget for review and approval by the board, which again is also an iterative process. And then moving up to the maroon box, our teams continue to measure and track performance throughout the fiscal year, and we'll be committed to providing more regular updates to the board on that progress. And now Kim will walk us through more detail.
Next slide, please. Anissa shared what's called a PDCA cycle, plan, do, check, adjust cycle, an annual problem-solving cycle, and I'll elaborate. Where should we focus our efforts to impact our system performance in FY27? What matters the most? Well, it starts with measuring what matters. So KPIs enable us to see if our activities are producing expected results and where we have problems, areas that need special attention. So I think health maintenance. We challenge our teams to get better at what they do in a few select areas. We create problems through OKRs for the organization to solve. Think health improvement. Next slide, please. We surface problems by visualizing them. So this is an example of a KPI, access KPI, and we're not happy with our current performance. Access is a broad problem. Realizing that we cannot solve access all at once, we should focus our efforts on where the greatest need in the community is, location, or service line. What matters the most in FY27? We then develop objectives, key results, and initiatives and track progress toward the goal to learn if we chose the right initiatives. And we adjust if we didn't. Next slide, please. We're in the process of creating structures to share problems, progress, results, and learning on all levels of the organization, frontline teams to ELT. The structures are mainly there for learning. We plan, we take action, implement our initiatives, learn by doing, and reflect in daily, weekly, monthly, quarterly, and annual meetings to see if we're making progress. And if not, we adjust the plan, try something different. And what we're also learning, bringing attention to problems seems to go against human nature. Pointing out our problems is hard, feels very uncomfortable, but we're creating a culture for people to feel safe, to fail. So this is our ultimate challenge. Welcome problems, find success.
Yeah, next slide, please. So last slide, this is our annual fiscal year 2027 budget planning calendar. So it goes from left to right. We are at the far left column. The structure of this calendar is designed to have an initial meeting to discuss and present items with a subsequent meeting to come in for the approval process. In the 5 areas that Dr. Lee mentioned earlier, that's the case. In all of those areas, the budget approval process is actually a very long process, and there are a lot of additional steps required, both from a statutory standpoint and just a process standpoint, and then certainly not only presenting here at Central Health, but also the Travis County Commissioners Court. So just kind of walking through quickly, beginning in March, you see anything where we're discussing items, there's a subsequent approval process beginning in March for the both the driving forces and the board policies scheduled for consideration on March 25th. In April, the system OKRs that we had talked about, and then again in May as we walk through the KPIs, again there's a discussion point of it in a prior meeting, and then subsequent meeting to consider approval. We then go through the budget process, which really kicks off with the financial forecast, which you see in June. And also as we wrap up our business initiatives, budget initiatives for beginning to present the proposed budget, which is scheduled for the 22nd. We have a couple of additional meetings to discuss the budget process. We do have to approve a tax rate for our public hearing, which is scheduled on the 28th. And then we come back in September for both the public hearing and subsequent both tax rate and budget approval in excuse me, in September. So that's the kind of again, this calendar has been fluid in the past. This is a proposed framework that we're presenting. And then the bottom half of the calendar just shows some of the timelines that exist in the FY27 budget process, and then some key dates related to some of the public conversation sessions that are scheduled. So that concludes our presentation, and be happy to answer any questions.
Thank you all. Manager Jefferson.
I noticed that the community conversations will begin early next month. And when I attended the community conversation in my precinct a year ago, I felt like at that time there was a presentation on what Central Health was anticipating would be in the next budget. And so I'm wondering if that format continues, how do we know what that content is going to be that soon? I would like to know what that content will be myself.
Maybe I can begin to respond to that, Manager Jefferson. So we won't know what the budget's contents will be in March, for example. By July, we might have a little more idea. And so some of the content, I think, will get tuned up as we understand the direction we're heading in. Linking to the presentation that Ted shared just prior, part of the opportunity here is to really increase awareness over who we are and the work we are doing now around access, affordability, value for the community. And so that's the main body, I think, of content. And then we want to do a lot of listening in these conversations. I think a higher proportion of listening than perhaps we've done last year. And also hoping to incorporate the voice of board managers from the Central Health Board and potentially, if community care board members are there, for example, assistant board members. So they are really as much about listening to the community's priorities as they are about communicating, where we are, and we won't know yet where we're going until later in the process cycle. I'm not sure if that helps answer the question.
Yeah, could I add just a slight, so yes, listening is exactly what we're trying to accomplish. I think there's been some criticism in prior years that the budget's already done, it's completed, it's so-called baked, and now we're soliciting input. So we're trying to have input early in the process so that we can develop the budget and take that input into consideration.
So, and then in terms of the policies that will be worked on and presented, just as a matter of process, I would prefer that the board have an opportunity to see a proposed policy before it's slated for action. It's just kind of hard to react and then vote at the same time. And it looks like that doesn't happen anyway from the meetings I've been attending. So if that can be, schedule at least a first and second reading, kind of thing.
Yes, Manager Jefferson, it's going to be a tight timeline, but our intention is to present either all 5 of those policies or at least as many as we can get drafted on the March 9th, our next meeting, and then potentially take action on March 25th. And so informational action, as you're suggesting.
I would just add that from the work that our governance consultant is going to be helping us, this is just what you're asking for. Like, we think there's a opportunity to put in writing what the board expectations should be with the administration and what the administration is capable of doing for us, whether it's 3 days, 7 days, 30 days out in terms of policies, because I don't think, at least what I observed about our own board, I don't think we're interested in approving anything that's just coming to us the day of. And I think the question is, well, what is the appropriate time? And that's a healthy tension between them. I think the other thing I would just mention from Manager Jefferson's comments, Dr. Lee, is I think if depending on what time you finish these presentations or the community conversation, if you have presentations, it would be helpful, I think, to send those to the board as an FYI, because sometimes the board is not there, but as you're seeing, you have a very engaged board that wants to be informed. I think that's just a simple FYI to all of us about what it is that you're going to present, so there aren't any kind of surprises about like the budget or things that I think maybe would precipitate some of the kind of concerns about presentations that are presented out there that we're not aware of. So I think that would be helpful.
Yes, absolutely. Yeah. Thank you for calling that. I'm sorry I forgot to speak to that, Manager Jefferson. So certainly we're happy to share the the proposed run of show and the slide deck, and also after the community conversation, we typically coalesce some of what we heard, and we will share that as well. So both before and after, we're happy to share that.
Manager Kitchen, did you have?
Yeah.
Your light is on, so.
Yes, no, it's on. So, a couple of things that, that I want to highlight, not necessarily to talk about today, but things that I would expect as a process that we might need to talk about on March 9th, just to, for a heads up. So a couple of things on the KPIs versus the OKRs. Okay, thank you for that explanation. It seems to me that we're talking about a process that moves towards multi-year, or at least multi-year KPIs, perhaps, if I'm understanding what we're talking about. And then I'm also thinking, are we reversing it? Because we're talking about our OKRs in April, but we're talking about our KPIs in May. Don't the KPIs drive the OKRs, or am I wrong about that?
You're absolutely correct. So that's a mistake in the deck.
So this timeline will be adjusted, so we do the KPIs first?
I would recommend we do. Yeah. I think we should know the performance of the system and then decide, what we're not pleased
Okay.
with.
Okay, well then I'll just note it, because April 22nd says OKRs, May 13th says KPIs, so just reverse that. Okay, so so then my second question is then let's see, what was it? I'm sorry. It occurs to me on the board policies that given the timeline, we really need to see them next week. If we're going to talk about them on March 9th, then we really need to see them a number of days in advance to really dig into them on March 9th, and then have time to think of them and vote on them by March 28th. So I just wanted to point out, because March 9th is week after next, so it is Monday, week after next. So I just wanted to point that out. And then I think of the 5 policies you mentioned, most of them make sense, but I'm not quite understanding what the second and third one were supposed to be. The second one is annual planning process, and the third one is annual budget process. Did I hear that right? If there's time, Chair, I'd like to understand what the scope of that is, unless you want to talk about that later.
Do you have a quick response? If so,
The other
or
ones
we
are
could-
self-explanatory to me, but yeah.
The quick response is the annual planning process is largely the content of what we are proposing here,
Okay.
but codified, and the
Okay.
board. So, for example, if we reverse the KPIs and OKRs, that's the board's
Okay,
prerogative.
so it's an annual budget process.
Yeah, it's sort of spelling out, so
Okay.
we're now following board direction on the process. And then the budget is more around, like, how are we managing that budget? And it's more on sort of Jeff's. So annual planning more on sort of the strategic side,
Okay.
annual budget more on the financial side. They obviously work together.
Okay.
But that's the general concept. And I hear you about next week, Manager Kitchen. We're working hard at work, and we may get them to you one by one as they are ready to be shared,
that's
just so that
okay.
you have time to look at them.
That's okay.
But yeah, we're working hard to get them to you.
Okay, then my last question has to do with the strategic plan. So, we're not gonna have, we won't have a strategic plan for this budget cycle, right? I can't remember when we'd have it approved, but it's not gonna be approved in this timeline. It's not even, okay, great. Then, just wanted to confirm that. And then I just wanted to comment on what we are working to accomplish. Those 2 points come out of I think are meant to track the direction we passed on system transformation. Is that right?
That's
Well,
correct.
they're missing a major point. And that point is within the same language that the first 2 points are. And that was the point about and I'm not gonna get the language exactly right, but it's the point about our partnerships, and not duplicating services. It's the point about building strong partnerships. So you really need a third bullet there, because if these two things are driving how we think about the budget, the third point I just mentioned also drives how we think about the budget. Does that make sense? Okay. All right, that's all I have right now, Chair.
Yeah, and just to clarify, is it one of the policies about the community partnerships? Yeah, so that will all be part of it.
No, I'm not talking about, they're talking about, they're talking about contracting with CBOs as one of their policies. That's not the same as what's in the strategic transformation plan,
Got it. For our partners.
I think.
Yeah. You're distinguishing partners and CBOs, and I get that.
Right,
Yeah, I get that.
right.
Okay.
Differently.
Yeah, yeah.
I thought,
You're separating them differently.
yeah,
Yeah, that's my understanding.
yeah, okay, okay. I thought, let me back up.
Sure.
I assumed when I heard the policy in contracting with the community organizations, I thought that was the policy that we've been talking about for a while, which is, goes back to your concern and other concerns.
Yeah.
So that makes sense to me. What's in the strategic, the direction on the system transformation plan is not that. It's very different.
Talking about partnerships.
It talks about, and I can't remember the exact language because it talks about, the language is about prioritizing our system within the context of developing strong partnerships and not duplicating services. So it's another concept that needs to go here. Does that make sense?
Further flush it out.
Yeah.
And to,
Right.
and to-
No, it's not
Yeah.
it's not a
I
policy.
hear you.
It goes here.
right, I hear you. I just want to go back to Manager Valadez about Dr. Lee just confirming that that's.
Yes. Did you hear what
I heard, and I asked, I think literally the same question to the team today. We needed to define CBO, right? What is a CBO? What is not a CBO? For this very reason. So, for example, it should be clear that I think Integral Care is not a CBO for the purposes of that policy, but the policy has to be clear. And so these are the kinds of points that as I take this first look at it, we need clarity, and then of course the board will provide the lens and further clarity as you review
It's the
it.
first time really identifying our CBOs.
Oh, Mike.
That's right. That's right.
It's our first time identifying these CBOs and formalizing them into our process as well.
That's right.
Yeah, and then let's just get some confirmation that when I'm talking about the system transformation plan and the language I just mentioned, that's not going to be addressed in this policy you're talking about. Are we on the same page?
Which policy, Manager Kitchen?
The first one you mentioned, the contracts with community organizations.
I think those
It
are
shouldn't
likely
be.
different issues. Yeah, likely different issues.
Yeah, I just
Yeah.
wanted to hear confirmation from him,
Yeah.
right?
I believe those are different issues, and
Yes,
as I said, we'll be presenting these 5 policies. Those might not be in the right buckets. The board may choose to move them around. Our intent is to try to put a policy framework around the board-approved system transformation resolution. This is a first stab at it. It won't be perfect, and we want to get it to you soon enough that you really can mark it up and we can bring it back for a robust discussion.
Yes, but I'm still not hearing confirmation of what I was saying. So the policy that you're gonna bring us is the contracting with community organizations, okay?
Organizations, right.
That's a different, go
Yeah,
ahead.
if I may, because I'm the one that's been kind of behind that, and this is my thinking. Community-based organizations would be the smaller organizations that come to us that we have generously funded because they are part of our wraparound services. We want to be part of the community.
Right.
And those are smaller amounts of money, leading up to about 5 million last year. But that being said, those are going to be those small ones. The partners part of it are Integral Care, for example. Those we're going to treat differently in the transformation policy.
That's right.
Is how I see
That's
it.
right.
Okay?
That's right.
And now, what I would just say is that because it's the CBO piece of it, we are just now beginning to put definition around it. We don't have it totally figured out, so just kind of, we're gonna beg patience here. We're figuring it out, and we want you to help us figure it out too, right? That's why we wanna bring it to you, and that's why we're gonna have that. So I'm just putting that out there, cause that's not completely figured out. So you're right on target, Ann. I appreciate that, because you're absolutely on target.
Okay.
So, Dr. Lee, Jeff, Kim, and Lisa, thank you very much for the presentation. Members,
But we still have, are we not gonna ask the rest of us?
oh, I'm sorry. Yes, I'm sorry. I apologize. I think I cut you all off and you have questions. And I think if you want to send them to Dr. Lee and email them, that would be incredibly gracious so that we can move to the next item.
CC the chairman.
Yes.
I
And
agree.
CC me.
But the reason I made the comment that I made earlier is because it makes sense to me
Yeah.
that as soon as we're through with this fiscal year, we're working on next year's fiscal year and not waiting till March.
Yeah. That's
Do
good
you
feedback.
understand?
Yeah,
That
no,
is
that's
what
good
I
feedback.
said. So in October of this year, I expect for us to be doing this front part. By the time we're through with December and getting ready to go holiday traveling or whatever, it's done. We're getting ready for the rest of the year.
I think your point is very duly noted and could be put into the policies that they're
Because,
drafting.
and the reason I'm saying that is because as we're reviewing these various contracts and things like that, we are also looking at efficiencies that would be taken away, gained,
total
learned,
sense.
lessons learned, and we wouldn't have to make these little contracts, okay,
Yeah,
with the others in the future years coming, okay?
yeah. The sequencing makes sense. And I
That's
think
exactly right.
we'll be able to insert or have a discussion about that when we see the
And-
draft policies.
And to me,
then
that
figure it
goes
out.
to the whole process of what we feel is an efficient organization. Are we internalizing
Sure.
those responsibilities as opposed to outsourcing them?
Yeah.
And I'm one of those that wants to internalize as opposed to outsource.
Thank you. Manager Matwani, did you have a?
Thanks.
Okay, thank you. Okay, so we're gonna move on and I'm gonna announce that the board is convening in closed session to discuss agenda items 6, 7, 10, and 11 under Texas Government Code 551.071, consultation with attorney, and agenda item 8, 9, and 12 under Texas Government Code 551.074, personnel matters, and Texas Government Code 551.071, consultation with attorney. So, do I need to also?
You have
say
to
the
read
date?
all
Yeah.
this,
So,
yeah. For this one
today
you do.
is February
25th.
25th, 2026, and it is now 7:34 PM. But the attorneys and Dr. Lee, no, Dr. Lee's, no, Dr. Lee and the attorneys are here. Well, and I don't know who else is supposed to be in here. What? Well, let me go back for 1 second. Going to be in executive session for item number 6, discuss and take appropriate action on the hiring of a board governance consultant. Item 7, discuss and take appropriate action on the required documentation of closed sessions of Central Health Board of Managers and committee meetings. Item number 8, discuss and take appropriate action to approve the president and CEO's goals for fiscal year 2026. Item number 9, deliberation and possible action on the appointment, employment evaluation, reassignment duties, discipline, or dismissal of one or more Central Health employees. Item number 10, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN 17005824 in the 345th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. Item 11, receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family. Cause number D1GN 230000398. And item 12, review and take appropriate action on the Community Care CEO Employment Agreement. And is now
I don't think you're-
7:36 p.m.
I don't think you read 6, the one about the contract. I was paying attention and I don't think you read it.
I read items 6, 7,
Okay.
8, 9,
I missed
10,
6. Sorry.
11, and 12.
Okay, we're good.
Okay, great. Good evening. It is now February 25th, 2026 at 10:22 PM, and we are now back in open session. And members, the only item we have is item 13, which is to confirm the next meeting, which will be of the Central Health Board of Managers, which is tentatively scheduled for Wednesday, March 25th at 4 PM at Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment.
Chair,
Yes.
well, can I don't want to
haven't
say,
accepted
I can
anything
second
yet.
it so we can debate, but I don't know, do we need to vote on the CEO goals or?
I think we just gave direction. I don't think we need to vote unless,
Okay.
Felicia, you think,
Do we need to vote on those?
You hadn't decided anything. You discussed and you took the temperature.
okay. So without
So-
everybody here, I'd rather just,
You can carry it over to the
yeah,
next.
we just carry it over. So I'm gonna accept the motion for adjournment from Melissa May and second from, Manager Matwani. All those in favor, please raise your hand.
Aye.
The motion passes unanimously and the meeting is adjourned at 10:23 PM. Thank you.